with myopia ranging from 1 to 10 diopters and astigmatism ranging between 0.5 to 4 diopters with a maximum spherical equivalent of 10 diopters, with an exclusion criteria of anything that affects the vision, be it corneal pathologies, retinal pathologies, cataract, glaucoma, etc., and pregnancy because of refractive change. All patients underwent a complete ophthalmic assessment preoperatively, and manifest refraction was repeated on the day of the procedure. Post the surgery, follow-ups were on POD 1, 2 weeks and 3 months. Coming to the results, the efficacy index was 1.01, which basically is that 98% of the eyes had a UDVA of 20/20 or better at 3 months post-op. Safety index was 1.61, that is at 3 months, 18.4% of the eyes had gained 1 line of CDVA, 72.4% of the eyes had no change in CDVA, and loss of 1 line was noted in about 9.2% of the eyes. And in this 9.2%, 78.9% of these patients had a CDVA of 20/20 or better, and no eyes lost 2 or more lines. The spherical equivalent was within 0.5 diopters and 99% eyes, and 100% were within 1 diopter, which shows that there was no significant under or overcorrection. Stability, the mean change in spherical equivalent at 3 months was 0.016, which points towards good stability in the refraction at 3 months. And astigmatism of 98.4% of the eyes had an astigmatism less than 0.5 diopters, and 100% were within 1 diopter. The OSI, which stands for Objective Scatter Index, was average pre-op values of 0.73 and post-op was 0.084. So our study showed that 98% of the eyes had a UDVA of 20/20 or better, and 99% had a spherical equivalent within 0.5 diopters at 3 months. Other studies with a smaller cohort by Reinstein et al. And Saad et al., the cohort was less than 200 eyes. It showed 91 and 93% of the eyes with a UDVA of 20/20, and 86% and 91% had a spherical equivalent within 0.5 diopters at 3 months. This could be attributed to a larger cohort of our study, and it could also be because of the optimization of the laser energy in our unit over time. 18.4% of the eyes showed a gain, and 9.2% reported a loss of 1 line at 3 months. It was comparable to a study by Reinstein et al., showing gain of 1 line in 15% and loss of 1 line in 8%. 98.4% had a residual astigmatism of less than 0.5 diopters. This could be attributed to the Oculine software. Safety index of 1.6 and efficacy index of 1.01 was seen in our study, which was an improvement from the Visumax 500 study in our own institution, and also by a study done by Moshirfer et al. On Visumax 500. The mean change in OSI was 0.11 at 3 months, but it was still within the normal range of 0 to 1 values. Suction loss was seen in 1 eye, which was about 0.06% compared to the 0.5% seen in Visumax 500. So this was a 88% reduction in the suction loss rate. And the limitation of our study was that it was just a 3-month follow-up, but previous research has indicated that the refractive stability is typically achieved within this time frame, and also due to a larger sample size, our outcomes which were observed are more reliable and statistically sound. So to conclude, the Visumax 800 is safe and effective in treating compound myopic astigmatism with robust results, including excellent visual outcomes and refractive stability. Thank you.
Any questions from the judges?
Hello. Yeah. Good morning, everybody. See, 2 brief questions. One, your range of correction was from 1 to 10 diopters, right? So even the 10 diopters were astigmatism alone or with a spherical equivalent? Spherical.
Astigmatism was a maximum of 4 diopters.
Yeah. 3-month follow-up.
Yes.
The extreme cases, how many required resurgeries?
No resurgeries were done, ma'am. No resurgeries.
And they were happy with the outcome of the procedure?
Yes, ma'am.
Yes?
Majority of the patients has 6/5 vision, but a few of them were lesser. So we've kept it as 98% of 6/6 vision.
Yeah, drawback you said was 3 months.
Yes, 3 months follow-up.
6 months to 1 year, what I have seen, any LASIK procedures, all these procedures over a period of time,
Yes.
they come back with more than 1 to 2 diopters much later.
Okay.
So what is your cover-up for that range of?
Ma'am, our study started from 2021, so there was even a 1-year follow-up in which patients have maintained 6/6 vision, ma'am.
Okay. Thank you very much.
Thank you, ma'am.
Paper? ಬ್ರೈಟ್ನೆಸ್ ಇನ್ಕ್ರೀಸ್ ಮಾಡೋಕ್ಕಾಗತ್ತಾ?
Good morning, I'm Dr. Dhananjay. I'll be talking on impact of smile on corneal and corneal epithelial aberrations and corneal spherical aberrations post-smile in various severities of myopia. Smile has become now the mainstay for treatment of refractive errors. So why to study these aberrations? Smile causes various corneal and spherical aberrations post-surgery, which results in it would be interesting to understand the normal contribution of the epithelium in aberrations compared to the corneal aberrations. MS39 was the tool used to assess the aberrations post-operatively. The aim to evaluate the post-operative epithelial and corneal aberrations in patients undergoing smile for low, moderate, and high myopia. According to the preoperative spherical equivalent, the eyes were divided into 3 groups: the low, moderate, and high myopia. The sample size of the study was 150, where 50 patients were divided into each groups of low, moderate, and high myopia. The study was retrospective. Post-operatively, the patients were followed up on day 1, post-operative 2 weeks, 3 months, and 6 months, and they were again assessed for aberrations on MS39. The results after 6 months showed that epithelial aberrations were almost similar in the varying degrees of the varying degrees of myopia, whereas the spherical aberrations, corneal spherical aberrations were were directly proportional to the severities of the myopia preoperatively. So the corneal shape changes from its natural prolate aspheric optical architecture to an oblate surface after myopic laser correction. There is flattening of the central cornea and change toward the positive aspherity. Such an outcome would worsen the spherical aberrations, explaining the significant change in the spherical aberrations after smile surgery. A thicker stromal lenticule from higher myopic correction could result in larger change in anterior corneal aspherity, explaining greater spherical aberrations induced in patients with higher myopia. To conclude, while correcting different grades of myopia with smile, the most significant change was observed in corneal spherical aberrations. Corneal spherical aberrations increased in proportion to the degree of the myopia corrected, and epithelial aberrations profile did not seem to differ significantly between the groups. Thank you.
The judges have any questions, ma'am?
Anybody from the audience also can ask questions, because see, we've never been through this kind of training in our whatever working days. So if you have anything that needs to be, clarified, you can ask. No problem. Okay. So your patient cohort was about 150 patients
150, ma'am, yes.
divided into three
3 groups, yes, ma'am.
3 groups. Anything that you saw in the difference between the 3
Post-operatively,
post-operatively?
the visual outcome was very much similar, ma'am. The spherical aberrations which we assessed was definitely higher with higher myopias, patients with high myopias. Apart from that, ma'am,
No problem. Patient wasn't complaining about anything following the smile technique.
no,
No.
ma'am.
Satisfied.
Yes, ma'am.
Thank you.
The next patient? Can the next speaker come until then? 4? Was it 4?
Good morning, everyone. I'm Dr. Shraddha. I'm presenting a case of chronic cicatrizing conjunctivitis. I would like to call it a test match with tobramycin. Chronic cicatrizing conjunctivitis refers to a condition characterized by inflammation and scarring of the conjunctiva. The severity of cicatrization varies from subtle conjunctival fibrosis to significant distortion of the ocular surface anatomy. This can be triggered by a range of local irritants and systemic diseases. It can either be a standalone ocular or a multisystem disorder. The most important causes include cicatricial pemphigoid, Stevens-Johnson syndrome, or the toxic epidermal necrolysis, a drug-induced cicatricial conjunctivitis, rosacea, and a battery of other immunological conditions. Distinguishing the cause for chronic cicatricial conjunctivitis helps in the treatment and appropriate management of its sequel. A case report of a 60-year-old woman who presented to us with redness, watering, severe photophobia, and diminution of vision in both eyes. She had a brief history of just 1 month. She had a past history of cataract surgery in both eyes 15 years ago, but she had a history of use of tobramycin plus fluorometholone eye drops, which was over the counter, since 4 years in both eyes. She had no history of any systemic illness. Her vision was hand movements in the right eye, 6/60 in the left eye. Eyelids showed a loss of canthal architecture. It had rounded canthal margins. Loss of canthal architecture was also noted in the left eye. The lacrimal system showed punctal stenosis in both eyes. Conjunctiva had conjunctival congestion and fornical shortening in the right eye and conjunctival congestion in the left eye. Cornea, the surface sheen was lost in both eyes. She had a 360-degree vascularization in the right eye and an epithelial defect of 2 into 2 millimeter in the left eye. Other examinations are the lens, right eye was aphakic and left eye was pseudophakic. On dry eye evaluation, she had a T-BUT of 1 second in both eyes, but a reflex steering gave a Schirmer's of 35 millimeter. On systemic examination, on oral examination, there was oral mucosal fibrosis and she had very poor dental health. So, the corneal vascularization and fornical shortening with punctal stenosis led to a presumed diagnosis of chronic cicatricial conjunctivitis in both eyes. Tobramycin, being a known cause for this acquired punctal stenosis, was presumed to be the cause. However, the presence of oral mucosal fibrosis on systemic examination and the profile of the patient, being she was an elderly female, led to the suspicion of ocular cicatricial pemphigoid. So, mucosal biopsy was done to rule out OCP. So, the HPE showed, conjunctival biopsy showed dense mononuclear infiltrate with atrophic epithelium and fibrosis, suggestive of a possible autoimmune disease or IgG4 disease. She was immediately asked to stop the drops, started on artificial tears, and then referred to an immunologist for the further management. So, long-term use of any topical medication can cause CCC either due to the medication itself or the preservatives used. Steroid antibiotic combinations and drugs are containing the preservative BAK are also known to cause punctal congestion syndrome. The preservatives and anti-glaucoma medications are the more frequently inciting DICC, that is drug-induced. The course of mucous membrane pemphigoid or OCP is characterized by slow progression from chronic conjunctivitis to subepithelial fibrosis, fornical shortening, symblepharon, ankylobrophenon, and ocular surface keratinization. So, in conclusion, the accurate diagnosis of MPP or OCP is crucial due to its disease progression and its challenge positioning in distinguishing from other causes of conjunctivitis. It is important to consider differential diagnosis in an elderly female.
See, you've attributed it totally to tobramycin and fluorometholone.
First,
See, likely
first.
that she may not have used it in a regular basis. Tobramycin is something that is used universally for all children with conjunctivitis because that is a known treatment.
Yes.
Okay. So in this patient, there are subsequent factors like submucosal fibrosis in the mouth.
That's
so
the reason.
The history should have included her use of non-use of tobacco. Very important because submucosal fibrosis in a person who's used to keeping little bits of tobacco in the mouth, very important to rule out. Single use of a drug, either due to the preservative or the drug itself, unlikely I feel that it could have caused the stenosis.
That's why it led to
Or
the diagnosis of OCP due to the.
Yeah, that is likely.
That is likely.
And the second thing is that punctal stenosis, see, we use it on and off for most patients.
Yes.
I've never seen one so far. Children do get conjunctivitis, especially NLDs. So we use it rampantly and we've never seen this kind of a thing before.
Yes.
Thank you. Any questions from the audience?
Good morning to one and all present here. I'm Dr. Dimple and I'm here to present a case series on the ocular involvement in pediatric SJS and TN. So Stevens-Johnson syndrome and toxic epidermal necrolysis is a sensitivity mucocutaneous condition triggered mostly by medication and infection. So the ocular involvement can be severe in children and sometimes be life-threatening. So the aim of this case series was to describe the ocular manifestation and management of SJS and TEN in children. This was a retrospective case series of 5 children from the age group of 5 to 18 years with SJS or TN treated in the last 1 year. So coming to a patient characteristic, the age group which was selected was 5 to 18 years. Male to female ratio was 2:3. Number of SJS cases was 2 out of 5 and TN cases were 3 out of 5. All the patients were managed with topical steroids, antibiotics, and preservative-free tear substitute. Lid sweeping was done for those who had symblepharon, and one of the patients had amniotic membrane transplant. So the outcome of this, the drugs which were caused the condition was acyclovir, phenytoin, and spironolactone, which was taken all orally. Infection which induced SJS and TN was pneumonia and dengue. Corneal involvement and severe eye involvement, 4 out of 5 of the children had. Then drug-induced, 3 out of the 5 children had drug-induced conditions. Follow-up to few visits, only 3 out of the 5 children had come, and 1 had expired. So 4 out of 5 children had the severe eye involvement. So here you can see there's an epithelial defect of more than half of the cornea and also involving whole of the lower lid margin, and conjunctiva was also taking up the stain. Here you can see the skin erosions, and also the following pictures also show the same. So to conclude, pediatric SJS and TEN patients have more severe ocular complications than adults. So based on the severity, ocular involvement in SJS and TN can be classified into mild, moderate, and severe. So in this report, 4 out of 5 had severe ocular involvement. So early ophthalmic assessment and intensive management with frequent follow-up are the key factors for recovery. And these are my references. Thank you.
Thank you. See, everything is fine in the sense that, you have documented the skin changes and everything. But in these patients, you have to have a very, very long-term follow-up.
Yes, ma'am.
Here in John's, like it's all, right now I don't know whether there's that kind of intense, number of cases that come here because they're all referrals. So when they come, you have to, it's not just a one-day management. Your glass rod passing or whatever steroids that you use, all those also induce other problems in the patient. And being children, so many things are contraindicated. But the biggest thing is that they would have given outside treatment with some other unknown drug, which is the cause for it. So we generally give cards, say avoid all these things in these patients. So just as a matter of telling you what to do, you have to give that little card saying that avoid these drugs or avoid this thing, fever, dengue, especially now that it is very, very rampant. Look out for skin changes. Even a small rash, there's a sudden peel off. Thank you.
Good morning. My topic for today is comparison of peripheral refraction in myopia, hypermetropes and emetropes. In the recent years, interest in peripheral refraction has increased. It has been shown that defocus in the retinal periphery might influence the development of myopia. Several studies have reported differences in the peripheral refraction patterns in emetropia, myopia, and hypermetropia, which showed emetropia and hypermetropia had relative myopic shift and myopia had relative hypermetropic shift. The aim of my study is to study the relation between the peripheral refraction, the keratometry values, axial length in all the 3 groups, and my objective is to compare the peripheral refraction status in all the 3 groups. This is a cross-sectional observational study done on 88 patients over the time period of 3 months. Institutional ethics approval was obtained. We had included kids between the age group of 8 to 18 years and excluded kids with corneal opacities or prior corneal surgeries. They were divided into 3 groups. One was myopia, hypermetropia, and emetropia. And manual peripheral refraction was done at a distance of 2 meters with target placed on the stuck on the walls. Data was analyzed using SPSS 26 software and mean width standard deviation of keratometry, axial length, peripheral refraction was done. And using ANOVA test, the comparison between the comparison of peripheral refraction, refractive error was done in these three groups. Demographic statistics, mean age of 11.1 years. The age range was between 8 to 18 years, of which 41 were females and 47 were males. Emetropes of mean age 11.3 years, ranging from 8 to 16 years. 12 were males, 12 were females, and 16 were males. Myopes, mean age of 11 to 1.5 years, ranging from 8 to 18 years, where 16 were females and 14 were males. Hypermetropes, mean age of 11.14 years, age ranging from 8 to 15 years, where 13 were females and 17 were males. These were the measurements that we had taken, all the data. The result, we compared 0 degree to nasal 45 degree and temporal 45 degree, and we could see change in all the three groups, but significant change was found in the hypermetropic group, which showed a myopic shift. In a study done by Caver et al. On peripheral refraction for distance and near vision in emetropes and myopes, it was done on 20 subjects, and it was found there was no significant difference between the refractive error groups, and no association between the myopes and peripheral refraction in distance and for near. In a study done by David et al. On peripheral refraction along the horizontal and the vertical fields in myopia, 116 subjects were taken into account, and it showed emetropes had peripheral myopic shift and myopes had peripheral hypermetropic shift in the horizontal field, but no significant shift in the vertical field. And the study conducted by us on 88 subjects showed myopic patient had peripheral hypermetropic shift in all the three, both nasally and temporally, in all the three degrees, and significant myopic shift in hypermetropic patients. Conclusion, here we had compared the age, gender, keratometry value, and axial length in all the three groups, and significant myopic shift was found in the hypermetropic group. Limitation of
It's a well compared group, meaning emetropia, myopia versus hypermetropia.
Yes.
But how practical is it? Because see, if you do a peripheral refraction, 100% you can't take that into consideration when you're trying to give the correction to the child, especially for children.
Yes.
You know, central refraction is what really matters. But as a scientific study, it's a good study because you have seen what is happening in the periphery also. Fixation for a child is very, very difficult. Meaning, if you ask them to look here, they'll be looking somewhere
Yes,
else. You know, so there's a practical, thing that I don't know how correctly the peripheral refraction was done. So other than that, it's
Yes,
an excellent study.
That's why we had taken a group from 8 to 18 years, so at least they will listen to
Yes,
us.
yes. That's a better thing. Yeah, young children, less than 6 years, 5 years, and
Yeah,
all
it's
that, you
very
cannot do it.
difficult.
You cannot. And practical implication is not like as if you can use that data, because always there's a social impact. You're doing that. What are you doing it for?
Yes, ma'am.
So that is the reason. Thank you.
Thank you.
Good morning, ma'am. I am Dr. Srishti K. standing in front of you to present a case report on netacidil-induced corneal verticillata. Netacidil is a rho kinase inhibitor used in the medical management of glaucoma and ocular hypertension. It is a novel drug that has been approved by FDA in December 2017. It acts by decreasing the actin stress filaments and also by decreasing the cell stiffness, which results in increased aqueous outflow through trabecular meshwork that results in decreased in intraocular pressure. It also acts as norepinephrine transporter inhibitor, causing vasoconstriction leading to decreased blood supply to the ciliary body, resulting in decreased aqueous humor production and reduced episcleral venous pressure. Netacidil is a well-tolerated drug with a good safety profile. Some of the common adverse effects encountered with netazoidil include conjunctival hyperemia, corneal verticillata, and subconjunctival hemorrhages. Coming to our case report, a 50-year-old male presented to our ophthalmology outpatient department with a history of 1 month post-cataract surgery done in left eye elsewhere, with complaints of pain and blurring of vision in the left eye. On clinical examination in the right eye, the uncorrected visual acuity was 6/24 and the best corrected visual acuity was 6/9. The anterior segment and fundus was found to be normal, with IOP being 15 mmHg. In the left eye, the uncorrected visual acuity was 6/36 and the best corrected visual acuity was 6/18. The anterior segment was found to be normal and the PCIOL was noted in the circus. The fundus was normal and the IOP was 32 mmHg. The patient was treated with topical moxifloxacin 0.5% with dexamethasone phosphate 0.1% 4 times a day and topical netazoidil 0.02% once a day. The patient was advised to follow up after 7 days. On the 7 days follow-up, the patient complained of increased blurring of vision in the left eye. On examination in the left eye, the unaided vision had worsened to counting finger 2 meter, and on slit lamp examination, we could see reticular corneal epithelial edema arranged in a honeycomb pattern. The IOP had come down to 24 mmHg. The right eye findings was within normal limits. The netazoidil was stopped immediately and the patient was started on brinzolamide 1% and timolol 0.5% eye drops twice a day along with prednisolone acetate eye drops 1% for 4 times a day. The patient was followed up subsequently and during the 3rd week follow-up, the patient was symptomatically better. And on examination, the left eye unaided vision had improved to 6/36 and the corneal edema was resolved with IOP being 18 mmHg. Right eye was within normal limits. Conclusion, reticular epithelial corneal edema is one of the common side effects seen with both netazoidil and ripazoidil. It occurs more frequently and with more severity and faster resolution with netazoidil as compared to ripazoidil. Patients with previous corneal edema and previous intraocular surgeries causing corneal endothelial cell loss are at potential risk for this epithelial corneal edema. This case report demonstrates one of the common side effects of netazoidil, that is reticular epithelial corneal edema, and also shows the reversibility of the same with the discontinuation of the drug. These are the references I had.
Yeah, good study. But why wasn't the steroid stopped? Because when you have a 32 tension, continuing moxifloxacin, dexamethasone, or even later putting the patient on prednisolone, the drug should be stopped first. That should be the first line of treatment because that is something well known to cause rise in intraocular pressure.
Yes.
Secondly, the drug may have the side effect that you have demonstrated by saying it's got a honeycomb epithelial pattern which is not so correct. All that is correct, but the primary intention is to reduce the intraocular pressure. Post-operatively, that should be the intention where you stop the drug, see what is the response to the treatment, then only. And so many other drugs are there in the market.
Yes.
And it is opting for, just because undergraduates always tell all these drugs as first line of treatment. We still follow the old school where we give timolol, brimonidine, all those things. Thank you.
Good morning, everyone. I'm Dr. Namita. I'm presenting the outcome of accelerated cross-linking based on cone locations in the keratoconus cases. So, corneal collagen cross-linking is a treatment designed to halt the progression of progressive keratoconus and the corneal ectasia. So, this works by strengthening the corneal structure by inducing the cross-links. So, the effectiveness of these changes could vary depending on the initial biomechanical properties of the cornea based on its topographic patterns. So we have taken this study to look at how this CXL is affecting on the preoperative topographic cone locations in the keratoconus cases. So we have included the 50 eyes of 39 patients who have undergone the cross-linking. Standard ophthalmic evaluation was done which included refraction, visual acuity, slit lamp biomicroscopy, fundus evaluation and the pentacam, which were obtained preoperatively and postoperatively at 6 months. So the cone locations was determined by the coordinates of the preoperative maximum K and was divided into 3 groups into central, paracentral and the peripheral cone group. So the result showed that there was a significant improvement in the UCVA and the maximum K, which showed a maximum K of flattening of one diopter and the UCVA of one line improvement. So the effectiveness of treatment in the central and the paracentral cone groups was due to the uniformity of the delivery and the diminishing effect towards the peripheral cone group. So the factors like non-homogeneous treatment delivery and the Kozan effect highlight the challenges in achieving the consistent treatment outcomes in the keratoconus cases. So we hypothesized that the initial corneal topography pattern may influence the consequent clinical outcomes. Though CXL was effective on whole, but further analysis on the cone location showed that there was a significant improvement in the central and the paracentral cone group and insignificant changes in the peripheral cone group. Thank you.
How long was the study done?
It was done for 1 year, ma'am. Yes.
Yeah, and all the patients uniformly improved, best corrected visual acuity was very good.
Yes, ma'am.
Okay.
Yes.
Yeah, no side effects of CX.
No side effects of sex.
Thank you.
Thank you.
A very warm good morning to everyone. So thank you for joining me here today. So I'm very delighted to present my paper on the topic of comparison of efficacy and safety of lipid-based lubricant eye drops, that is Systane Complete versus carboxymethyl cellulose drops in management of evaporative dry eye. I have no any conflicts of interest in promoting any of the brands mentioned over here. So as we all know, dry eye disease is a common ocular condition which is characterized by tear film instability, significantly impacting individuals, especially those with computer vision syndrome. Effective management of this condition is very crucial for improving the ocular comfort and visual function. So we have here Dewey's classification of dry eye, which is broadly divided into aqueous deficient and evaporative variety. So in our study, we were focusing mainly on the evaporative type of dry eye. So in this study, we have used advanced dry eye scan protocols, including interferometry, in order to assess the two distinct subtypes of evaporative dry eye, that is the meibomian gland dysfunction related loss and non-MGD related loss. So our sample size was 50 patients, 100 eyes of 50 patients were studied, and the age group was between 18 to 65. Study duration was 45 days, and baseline follow-up evaluations were done at day 1, 30 and 45 days. We included patients with evaporative dry eye based on our clinical evaluation, and we have confirmed them using the IDRA dry eye scan. We have excluded patients who had any history of ocular surgery, any history of trauma, or people or the patients whose Schirmer's was less than 10 millimeter. So our diagnostic criteria we have used is an integrated diagnostic for dry eye scan, which is a non-invasive procedure which provides a detailed analysis of tear film quality, quantity and stability, including the measurements of the tear breakup time, the 5 parameters I'll be discussing subsequently in my other slides. So the protocol of treatment was right eye we have administered Systane Complete, and the left eye was with carboxymethyl cellulose. This is the IDRA machine. So here is the daily dry eye report, which shows 5 parameters. So there is a proper color coding and graphical representation which helps in easy understanding of the values. So first parameter we studied was a non-invasive breakup time. So here this is a qualitative analysis of tear film stability. So it allows us to understand the how long the tear is able to protect and wet the ocular surface. This we studied in both the groups, that is Systane and CMC group. In both the study group, we have seen that there is a definitive improvement from the baseline values, but the p-value was more significant in Systane group compared to the CMC group. Next, we studied the lipid layer, which is studied based on the interferometry, which is a qualitative measure of measuring the secretion of meibomian glands. So here what we have seen is there was a improvement in the baseline values to the post-treatment values, but the p-values were much more significant in the lipid layer. Tear meniscus was also studied, and what we have seen is both the group equally responded to the treatment. And the meibomian gland loss was also studied, wherein there was significant, much more significant improvement in p-value in the cysteine group compared to the CMC group. We have also used the DQ questionnaire method in order to see how good the patient response is seen, and there was an improvement, average improvement from 18 to 10. So I would like to conclude by saying that both the drops, that is the lipid based lubricant as well as the CMC, are effective in management of evaporative dry eye. But yes, Cysteine Complete provides a faster relief and higher patient satisfaction. And yes, as the p-value was much more higher, significant in the Cysteine group compared to the CMC group. But definitely we need further studies with sample size for better follow. Thank you.
You have any financial interests?
No,
Yeah.
I don't have any
So you got dropping these trade names. No, so you can't do that in papers like this. And then if you have something, you have to disclose or non-disclose. Okay. Okay, sorry, I didn't see that. But still, you should not, I don't think it's a good idea to drop names in a presentation like this. Yeah. Second thing, why did you exclude Shermer's less than 10 mm?
Because Sherman less than 10 more is towards the aqueous deficient dry eye. So I have
Okay.
excluded less than 10.
Okay, sure.
Thank you.
Thank you.
My comments is also the same. You should never, never, ever use, names of a particular company. Even if you've declared it, it's not right to do that, because there shouldn't be a bias against what you use. Next time they'll go and say Cysteine is better, promote that. And cost-wise, I think the government has regulated tier substitutes to a particular amount, and you cannot exceed that. Thank you.
Good morning, everyone. I'm Dr. Babita. Today I'll be talking about my study, thinning rate of donor lenticule over 3 months and its correlation with visual acuity in DSEC patients. It is well known that endothelial keratoplasty has been accepted as a treatment of choice in corneal endothelial disorders. Descemet stripping automated endothelial keratoplasty provides a faster visual rehabilitation, reduced astigmatism and rejection rates, also substantial improvement in visual acuity. Yet the visual outcomes are often suboptimal due to graft irregularities, differences in graft thickness, donor-recipient interface, higher order aberrations, etc., to name a few. In this case series, we aim to compare the pre-operative or the pre-cut graft thickness with post-operative graft thickness, also to know if the pre-cut tissue has any bearing on the visual acuity. Ours was a prospective observational study for a duration of 3 to 4 months. Our sample size were 11 eyes of 11 patients. The study was conducted in patients, all the patients having pseudophakic bullous keratopathy as a diagnosis, and underwent a DSEC procedure alone. Donor graft thickness was provided by Lions International Eye Bank. The pre-cut tissue was prepared using a microkeratome. The donor characteristics were assessed where the mean endothelial cell density was 2850. Mean graft diameter was about 7.25 millimeters. And the mean thickness of the pre-cut tissue was around 118.5 microns. Our range of the pre-cut tissue was between 101 to 124 microns. The clinical data collected were the age of the patient, gender, indication for the surgery, preoperative best corrected visual acuity. Post-op follow-ups were done on the post-op day 1 week, 1 month, and 3 months. At each visit, post-operative best corrected visual acuity, anterior segment OCT, as well as specular microscopy was done. Our statistical methods used were, the descriptive and inferential methods, and the significance level was set at p-value less than 0.05. Coming to the results, out of the 11 eyes, the mean age was 61.09 years, and coming to gender distribution, 5 of the patients were male and 6 female. The mean graft thickness at preoperatively was 118.5. At 1 week post-op, the mean graft thickness had increased to 118.8. At 1 month, it had decreased to 105.4. At 3rd month, it was 91.64 microns. The mean thinning rate at different intervals calculated were at 1 week there was a 0.14 increase compared to the baseline. At 1 month, we saw a decrease by 6.5%, and at third month, we saw 13% decrease from the baseline. And the mean logMAR values at pre-op was 1.4, and it had improved to 0.5 at the third month. And this is the graph thickness and logMAR values at different time intervals. We did not find a significance. And the mean graft to recipient ratio was seen at 1 week, it was 0.2, at 1 month 0.24, and at third month 0.21, and we saw stabilization between 1 month and third month. To conclude, in our study, we found a gradual decrease or a thinning of the corneal graft and its stabilization by 3 to 4 months post-disc surgery. And we found a significant improvement in the best-corrected visual acuity with a hyperopic refractive shift. And we did not find any correlation between the best-corrected visual acuity and the graft thickness. Thank you.
It's a well-designed study, and I should compliment you that you went through the trouble of thing. What do you think was the attribute to the thinning of the graph that you put? You should give some explanation as to why it happened.
Yes, ma'am. So we found an initial increase in the thickness because probably due to the initial swelling of the graft, and followed by gradual thinning. It could be because our group was in the thinner range of 100 to 124 microns. All the pre-cut tissues were in that range. So they stabilized earlier, probably.
Just a word of caution to all these people. The study group was how many patients?
11 eyes, ma'am, 11 patients.
Eyes. So look at the pseudophakic bullous keratopathy that ends up giving a second surgery, which they are doing very well. So be careful when you're doing your intraocular lens implants and whatnot. Thank you.
Thank you.
Good morning, everyone. I'm Dr. Tindu. I'm going to talk about the safety, efficacy, and outcomes of topical insulin eye drops for refractory persistent corneal epithelial defects. Cornea is the outermost transparent layer of the eye, immediately anterior to the anterior chamber, iris, and pupil. It's an avascular structure and is nourished by aqueous humor and tears. The corneal epithelium acts as a principal barrier to fluid and pathogens. It is susceptible to common ocular pathologies such as aberrations and corneal epithelial defect. An acute epithelial defect in an otherwise healthy cornea is a lesion that usually heals within 7 to 14 days. Persistent epithelial defects are defined as corneal epithelial defect with a minimum area of 2 mm square that continue without improvement for more than 2 weeks despite conventional treatment. The standard care of persistent epithelial defect starts with conservative management and progresses to medical or surgical treatments if refractory. Insulin-like growth factors are crucial in growth, differentiation, and proliferation in corneal epithelial cells and act through insulin receptors and insulin-like growth factor receptors. The corneal keratocytes and epithelial cells express insulin-like growth factor 1, its receptors, and insulin receptors. The aim of the study is to assess the safety and efficacy of topical insulin eye drops for persistent corneal epithelial defects that are refractory to usual treatment in clinical practice and to evaluate the outcome. It's a prospective interventional study done from November 2023 to April 2024. Consecutive 16 patients who attended our OPD with refractory persistent corneal epithelial defect in defined period of time were considered for this study. We included patients more than 18 years of age with persistent epithelial defects in one or both the eyes with no improvement after standard treatment who visited our OPD between November 2023 and April 2024. And patients not willing to be included in this study, patients for whom follow-up was incomplete because they failed to attend the scheduled visit, and patients who had an absence of slit lamp images, all these patients were excluded from the study. We took a detailed history and thorough ocular examination was done. And epithelial defect area was graded from grade 1 to 3, grade 1 involving less than 1/4 of the corneal surface, grade 2 involving 1/4 to half, and grade 3 involving more than half of the corneal surface. The topical insulin eye drops were prepared at a concentration of 1 international unit per ml using regular insulin. 1/4 of the regular insulin is taken, which contains 10 units of insulin, which is added to 10 ml of artificial tears, which makes it 1 international unit per 1 ml. The risk benefits and treatment alternatives were discussed with the patients and verbal consent was taken. Topical insulin eye drops every 6 hourly was prescribed. Out of 16 patients, we had a maximum number of patients between 51 and 60 years of age, followed by 4 patients between 61 and 70 years. And we had 10 males and 6 female patients. And we had different causes of persistent epithelial defects like infectious keratitis, ocular trauma, ocular surgery, bullous keratopathy, lag of ophthalmos, and herpetic eye disease. At the end of 6 months, 13 patients achieved complete healing and significant reduction of persistent epithelial defect area. And 3 patients had a significant reduction of persistent epithelial defect area. In patients where complete healing is achieved, mean time taken for reepithelialization was 28 days. 90% reduction in persistent epithelial defect area was noted in the remaining patients. Patients tolerated topical insulin well, and no adverse effects or recurrences of epithelial defects were noted during the study period. In our study, the mean age at presentation was 49 years, and male to female ratio was 1.6:1. Etiology, as I've explained, infectious keratitis, ocular trauma, ocular surgery, bullous keratopathy, lag of ophthalmos, and herpetic eye disease. And patients achieved 81.25% of patients achieved complete healing, and the mean time taken for reepithelialization was 28 days.
Yeah. Do you get some kind of prepared insulin eye drops, or are you using the insulin drops that you
We are
have to prepare it?
preparing, ma'am, with the
How do you
regular-
prepare that?
1 ml of regular insulin contains 40 units, ma'am. So we are taking 1/4 of that insulin that will contain 10 units. So we are removing from the CMC, we will remove 1/4 ml. Then we will add this 1/4 insulin into the CMC. That
How
will
many
make-
days do you use it for?
We can refrigerate and use it for around 20 days to 1
Because
month,
see,
ma'am.
the risk is that once you draw it, it's an unsterile thing, and there's already epithelial defects which are prone for infections. Probably in your case, you know, you didn't
No, ma'am, we
encounter
didn't
any.
come across any
Yeah, but
infections,
if you do something like drawing something from something, I even hesitate to use betadine for patients because it's quite toxic. And insulin being whatever without preservative, putting it into a CMC solution and using it is a little risky, I feel. Thank you.
Thank you.
We'll just take a 5-minute break. I request the next session. Huh? Hasn't come as yet. Is Dr. Ria here? She hasn't come. So we'll move on to the next session, which is the retina session. So I request the presenters to just use these 5 minutes to check if your papers are already uploaded, right? And we'll start again in 5 minutes. Which is the retina session. So I request the presenters to please ensure that you're standing here. So when the first person finishes the presentation, the next person can immediately take over. And the same rules for those of you who weren't there when we set the first set of rules. So your presentation would be for a duration of 4 + 1 minute. So at the end of 4 minutes, you're going to hear a buzzer, which means you have just 1 minute more to wrap up. And at the end of 1 minute, the mic will automatically be turned off. So you can't continue beyond that. And then you have another additional minute that will be given for any questions. Okay, so if the judges have any questions, they'll ask you. Done. If there are any doubts, please just let us know. So we'd welcome Dr. Dimple to start.
Good morning to one and all present here. I'm Dr. Dimple, and I'm here to present a case report on bilateral choroidal osteoma secondary to Rosai-Dorfman disease. So Rosai-Dorfman disease is a rare benign tumor characterized by abundance of the histiocytes in the involved tissue. It is presented as a bilateral painless lymphadenopathy. So it can also present as an extranodal presentation mainly in the orbit, which include epibulbar mass, scleritis, uveitis, or serous retinal detachment with choroidal involvement. So choroidal osteoma is also a rare benign tumor which is characterized by a mature cancellous bone in the choroid, which can be either idiopathic or can occur secondary to a severe inflammation. So here a 12-year-old boy had come to our OPD, and he had a history of right eye proptosis since 5 years, which was painless and progressive. The proptosis worsened over the last 6 months. On examination, his visual acuity, color vision was normal, his pupils were brisk, and anterior segment was also normal. On Hertel's exophthalmometry, it was 26 millimeter in the right eye, and left eye was 21 millimeter, which is proptosis is more in the right eye than the left. The extraocular movements were limited on dextroversion, dextroelevation, and dextrodepression. On fundus examination, there's a bilateral yellowish-white elevated choroidal lesion with distinct geographical margins involving the posterior pole along the superior temporal and inferior temporal arcade and nasal quadrants pairing the macula. Here in the B scan, you can see a hyperreflective choroidal mass which was seen at the posterior pole in both eyes with acoustic shadowing giving the appearance of calcification. And even in the MRI, they had both eye had calcification in the posterior poles. So this is a previous MRI report which was done 5 years ago, which did not show any calcification in the posterior wall of the globe. Now coming to the management, the child had undergone a right lateral orbitotomy with biopsy, and the histopathological examination showed non-Langerhans cell histiocytosis with CD68 and S100 positive, which was suggestive of Rosai-Dorfman disease. The patient was eventually started on IV chemotherapy like vincristine and 6-mercaptopurine and also on oral steroids. So in conclusion here, the patient presented with gradually progressing proptosis, which on biopsy was found to be due to Rosai-Dorfman disease. The previous MRI scan did not show posterior pole calcification when the disease had presented and were only found in the subsequent scan, which was done 5 years later. So there were only few case reports which have association between the Rosai-Dorfman disease and the choroidal osteoma. So in the end, we can hypothesize that excessive compression over the choroidal vessels by the histiocytosis, in this case probably led to the posterior pole calcification. Thank you.
Yeah, your hypothesis is interesting, but in the MRI, the proptosis is more in the right compared to left, right? So then the compression should also be more on the right compared to left. But on B scan, the osteomas is almost equal in both eyes, right? So that is something against your hypothesis. Then what are the differentials of osteoma? Why did you just go with osteoma? It's a child with a proptosis and has these calcifications. What else do you think of? Did you rule out something? Any systemic evaluation was done?
Systemic evaluation was done. There was no other.
What was done? Like one of the most common DD will be some METs, okay, or some melanoma, amelanotic melanoma. So
but
for that,
on B scan it didn't show any dome elevation or high.
Yeah. But for METs you have to ideally do a PET scan.
See, the thing is, it's a rare case, no doubt about it, but bone-like presentation in the choroid, also you have to look for bony lesions elsewhere. Okay, so it's just not orbit, it's just not choroid. And treatment, of course, has been successful in that you've given the chemotherapy and the patient has responded. But this long-term follow-up is required for this child. It's a good case. Thank you.
Good morning everyone. So today I'll be presenting a case report on senior Loken syndrome, which is a rare yet significant bond between the eye and kidney. So what is senior Loken syndrome? Senior Loken syndrome, also known as hereditary renal retinal syndrome, is a rare congenital autosomal recessive disease which is characterized by nephronophthosis and retinal dystrophy. Nephronophthosis is a cortical medullary cystic disease of the kidneys. Then nephronophthosis is caused by 14 genes, 14 mutations in the genes of NPHP gene. Then senior Loken syndrome is caused by mutation in NPHP gene 1. The retinal lesions vary from mild pigmentary retinopathy to infantile retinal dystrophy to typical retinitis pigmentosa. Nephronophthosis usually progresses to end-stage renal disease by the age of first to second decade of age. Then this syndrome is associated with skeletal, dermatological and cerebellar anomalies. The presenting symptoms are usually polyuria, polydipsia and defective night vision. So presenting the case of an 11-year-old male child who was referred to ophthalmology OPD from nephrology for fundoscopy. The child is a known case of nephronophthosis with with ultrasound KUB showing bilateral hypodysplastic kidney. Child is a known case of hypertension with end-stage renal disease and uremic cardiomyopathy since 7 years of age. He is the only child born from non-consanguineous marriage. The child was started on continuous ambulatory peritoneal dialysis and was treated symptomatically by nephrology. The child had stunted growth with failure to thrive. The parents do not give history of any defective night vision. So coming to the ophthalmology evaluation, the vision in both the eyes was 6/6. Anterior segment examination on slit lamp was unremarkable in both the eyes. On confrontation test was normal. On indirect ophthalmoscopy using 20D lens, the media was clear, optic disc was pale with CDR of 0.3:1. The blood vessels, there was generalized attenuation that was seen, and macula, the foveal reflex was present. In the background, there were a few bony spicules and pigment clumping which was present in the mid periphery and the equator, which was suggestive of typical retinitis pigmentosa. The lesions were similar in the left eye and were almost symmetrical. So nephronophthosis is a progressive ciliopathy that is caused by dysfunction of primary cilia that connect the mechanosensory, visual, osmotic and other stimuli of the cell cycle control, leading to multi-system involvement and extrarenal manifestations. Retinitis pigmentosa also has syndromic association with other renal disorders such as the Bardet-Biedl syndrome. Senior Loken syndrome, though rare, it should be considered in a child with end-stage renal disease with retinal dystrophy changes. Cases like these highlight the importance of retinal examination in pediatric age group of end-stage renal disease and vice versa, which aids in timely management and detection of complications. Thank you.
Okay, it's a very rare case actually. But any other systemic associations other than kidney?
Ma'am, the patient had uremic cardiomyopathy as well, ma'am. And retinitis pigmentosa, he had anemia and he had failure to thrive.
Okay. Any associations with glaucoma or anything like that in this
No,
case?
ma'am. The IOP was normal.
See, the appearance on the disc pallor does not suggest a 6/6 vision.
Yes, ma'am.
Two, if at all the child had all the various things, even the pigments that you're showing is not typical retinitis pigmentosa. It is not typical because if you have retinitis pigmentosa, the pigments that are seen are very, very classic. So both those are little invariance to your presentation. That about it.
We tried doing it, ma'am. The child was not really cooperative. We used the
Good morning, I'm Dr. Srividya and I'm presenting on rickettsial retinitis, a single center experience from North Karnataka. Rickettsia is an obligate gram-negative intracellular bacteria and this is a zoonotic disease that spreads to human by the bites of these arthropods, that is mice, lice, flea and ticks. There are three major subgroups of rickettsial disease, that is a spotted fever group, the typhus group and the scrub typhus. This is a retrospective case series of 10 eyes of 5 patients who presented to KIMS Hubli Ophthalmology Department from November 2023 to April 2024. Over here we considered the presumed rickettsial retinitis group as our study group, that is the patients with recent history of fever, with or without skin rashes, retinitis lesions and a positive Weils-Felix test, which was considered when the titers are 1:160 or more, and a negative dengue, toxoplasma and chikungunya serology, as they present with very similar findings as that of the rickettsial retinitis. Here we report the demography, the visual acuity, posterior segment manifestations, visual outcome after treatment and association with rickettsial subtype of the disease. Over here we see that all the 5 patients were young adults and there was no particular sex predilection, and most of them presented with history of fever along with skin rash about 4 to 6 weeks before the ocular manifestation, suggesting a possible immunological mechanism, whereas one patient who was a young adult male gave a typical history of going to trekking, following which he developed such features. The best corrected visual acuity at presentation, most of them had a visual acuity poorer than 636 and it was as bad as counting finger 1 meter. All of them had a typical posterior pole presentation, that is grade 2 vitritis, along with multiple multifocal retinitis lesions, a typical macular star pattern, and macular edema in both the eyes. Then we sent for a batter of investigations which included Weil's Felix test, the toxoplasma, dengue and chikungunya serology test. And since all of them came negative except for the Weil's Felix test, we started on tab doxycycline and tab prednisolone in tapering doses. And on 6 weeks follow-up, we saw that most of them had gotten a vision back to 6/6, which was perfect vision. This is the first case of a 11-year-old boy who came positive for Indian tick typhus and had a typical feature of a macular star pattern, macular edema with a huge subretinal fluid correction. And after tab doxycycline 100 mg BD for 4 weeks and tab prednisolone 1 mg per kg body weight for 4 to 6 weeks in tapering doses, we see that the vision has returned back to 6/6 with a perfect OCT finding, and the vision came up to 6/12 in the left eye because of certain outer retinal degenerations. This is a case which came positive for scrub typhus, and his visual and his posterior pole findings were also very typical with vitritis, macular star pattern and macular edema, and after 6 weeks post-treatment his vision had come back to 6/6 in both the eyes. Therefore, I'd like to conclude by saying that retinitis with a recent history of fever with or without skin rashes, joints pain, and a positive Weil's Felix test suggests a rickettsial etiology. Its ocular manifestations could be an immune response to recent systemic rickettsial infection. In our study, we saw that 3 patients had come positive to Indian tick typhus. Although ocular rickettsial retinitis has an aggressive presentation, timely diagnosis and treatment with tab doxycycline 100 mg BD for 4 weeks with tab prednisolone 1 mg per kg body weight in tapering doses can yield a very good visual response within 6 weeks. These are my references. Thank you.
What was the duration after febrile illness?
All of them presented 4 to 6 weeks after the fever history, suggestive of a possible immunological response too.
Only if patient had macular edema, you started steroids, or even without macular edema also you started steroids?
All of them had vitritis also, ma'am, with a typical macular star pattern, multifocal retinitis lesion and macular edema. Because to control the inflammation, we started tab doxycycline, which also has anti-inflammatory property, and tabs and steroid prednisolone.
How did you identify individual typhus, like saying Indian typhus? And for my interest, I'm asking you.
We did Weil's Felix test, ma'am. It has OX2, OX19 and OXK. OX2 and OX19 is suggestive of Indian tick typhus. OX2 alone is suggestive of epidemic typhus, and OXK is suggestive of scrub typhus, ma'am.
That's a good investigation. Thank you.
Yes, thank you.
It's something that's done by bacteriology, microbiology department.
Yes,
okay.
Yes.
So on 10 patients, everybody had skin rashes, fever.
4 of them had typical skin rashes, ma'am. One of them came with trekking history and joints pain and fever, following which he developed decreased vision, ma'am. Thank you.
Good morning. I am Dr. Manoj. I'll be talking about the correlation of subfoveal choroidal thickness in high myopes with visual acuity and axial length. So high myopes are associated with reduced vision related quality due to the elongation of eyeball leading to lacunar cracks and choroidal neovascularization. This is due to the choroidal health which supplies the oxygen to the retina, and compromised circulation leads to thinning, which leads to vision loss. The advanced imaging technique like SDOCT enables precise measurement of subfoveal choroidal thickness. The primary object of this study is to assess the subfoveal choroidal thickness using SDOCT in patients with high myopes. The secondary objective is to evaluate the relationship between subfoveal choroidal thickness, axial length, visual acuity within this population. So there are 96 healthy eyes with spherical equivalence of more than -6 diopters. This is a prospective observational study conducted over 1 year. The patient underwent slit lamp examination with refraction assessment, visual acuity testing, axial length using IOL master. All the patients underwent spectral domain OCT. So in the results, the mean age was around 25 years old. Mean BCA was 0.20 plus or minus 0.26 log mar. The mean subfoveal choroidal thickness was 244.08. The mean spherical equivalence was -8, and mean axial length was 26.52. In our study, there was a negative correlation between VCV and subfoveal choroidal thickness. As the VCV decreased, even the subfoveal choroidal thickness also decreasing. And there was a negative correlation between the spherical equivalence and subfoveal choroidal thickness. As the spherical equivalence started increasing minors, there was a decreasing in subfoveal choroidal thickness. And there was also a correlation between negative correlation between axial length and subfoveal choroidal thickness. As the axial length keeps increasing, the subfoveal choroidal thickness started decreasing. So in conclusion, our study demonstrated a significant reduction in subfoveal choroidal thickness in this individual. There was a negative correlation between subfoveal choroidal thickness, visual acuity, and axial length. Unexplained cause of decreased vision in high myopes with clinical healthy macula. The probable culprit can be due to the thinned out subfoveal choroidal thickness. These are my references.
Any ICG was done? Because see, generally if you have a subchoroidal foveal thickness reduction, leak, loss of vision, ICG is the indicated thing.
Healthy macula was the inclusion, so we didn't do anything.
What you're seeing, healthy macula and myopes can be very deceptive, right? So their macula is different from a normal looking macula. So in most of the cases, even when they present with myopic CNVM, if the patient says the vision has come down and clinically you see nothing, you have to do an OCT. In OCT also sometimes you won't see. You need an angiogram to look for CNVMs because that is very, you can't see it properly. So your last line is very ambiguous, the conclusion line. Yeah?
It's treatable. See, finally what it boils down to is that the patient wants better vision. Whatever investigations we do, ultimately it has to give the patient some relief from whatever is happening. The high myopia, you say only 6 diopters, but I see up to 24 diopters, and those are the bigger risk patients. And if you don't do an OCT, angio or OCT itself, you're missing out on something. And if you can do an ICG, if you suspect some kind of choroidal neovascularization, it would add to the study. Thank you.
Good morning. I'm Dr. Riya, Junior Resident in Dr. Ambedkar Medical College Hospital. I'm here to present the topic study of peripheral retinal degeneration and its correlation with demographic factors and axial length in myopic eyes. Myopia is one of the most commonest refractive errors in general population. In myopes, there's an increased vulnerability to both disease and trauma due to thinner peripheral retina. There's a recent study done in 2022 by R.P. Prasad, Rajendra Prasad and Institute in Delhi that says that 63% of Indian population are myopic, and among that 39% have a risk of progressing to rhegmatogenous RD. Presence of poorly developed retinal elements, and there's a decreased resistance to vitreous traction, this causing myopes to progress to RD. The myopic eye is predisposed to retinal detachment due to peripheral retinal changes, which are most marked in globes of higher axial length. This study was conducted with a view to emphasize the need to describe these retinal changes and check the axial length in such eyes. The correlation of peripheral retinal degeneration, axial length, and the interrelationship between them and the factors such as age, sex, bilaterality, and area of distribution is the aim of this study. This study had 100 participants and 200 eyes who attended a refractive clinic at our hospital from June 2022 to December 23. The inclusion criteria were ages between 15 to 50 years of age, any gender, and myopia greater than 5 diopter. The exclusion criteria were patients with diabetic retinopathy, hypertensive retinopathy, any other known vascular diseases, and who are case of previous retinal and macular diseases and gross media opacities which interfere with ophthalmoscopy. The results were 63% of the eyes that were found to have some peripheral retinal degeneration.
there was an equal percentage of male patients having peripheral retinal degenerations as females, 50% each. And patients in 21 to 30 age group had 45% chances of having a lesion, followed by those in 31 to 40 years age group. The commonest degeneration was lattice at 20%, followed by white without pressure at 14%, pigmentary degeneration at 8%, and paving stone degeneration 4%, and retinoschisis at 2%. 14% of the patients had a posterior choroidal atrophy. In eyes with axial length of 25 millimeter, the percentage of patients with peripheral retinal degeneration was 50%, and above axial length of 28 millimeter, 100% of the patients had a peripheral retinal degeneration. So in conclusion, I would like to say that examination of retinal periphery, especially with scleral indentation, is very important in all myopic eyes, especially if the axial length is more than 25 millimeter. Lattice degeneration is the most common, with 60% predilection to bilaterality, and multiple lesions may be seen in 17% of the eyes. And if axial length exceeds 28 millimeter, all eyes have to be examined very thoroughly, because all 100% of eyes have shown peripheral retinal degeneration. Thank you.
Why didn't you take the pictures of the peripheral retinal degenerations? Because see, some of them are learning people. So if you had shown what a lattice looks like or whatever in these patients, that would have been a little more add-on to your presentation. With all the newer equipment, labs and things like that, photography of the periphery is quite okay. You can do it. Right? I'm just saying it as a next skill that you could have practiced in these same patients. Otherwise, it's good.
Thank you.
Because all myopics will have retinal degeneration, so that's very common. But this thing is axial length more than 28.
28, 100% chances of
They
having
will
a
have.
peripheral retinal degeneration is found.
Okay.
And 25, at axial length of 25, 50% of the patients had a peripheral retinal degeneration. So that was the
No, what was the common retinal degeneration you noticed in these patients?
Lattice was the most commonest that was noticed. Now at 20% was there.
But there was no mention of any holes in the lattice.
No, ma'am.
See, at least one hole you'll find. I'm telling you because we did the old time thing, right? And they're not, you necessarily need not treat every lattice that you see.
Yes, ma'am, with only holes.
Did you compare the degree of myopia, like mild, moderate, severe, to the axial length?
Ma'am, almost even at 5 diopters and even at 11 diopters, they seem to have lattice is common in all. And
Generally, how is it? Does the moderate myopes have more problems, or very high myopes have more peripheral retinal degeneration?
Moderate myopes have more.
Yeah, so that comparison, you said 4 and 11 had same, right?
Yes.
So usually moderates will have more of peripheral retinal degenerations. So that and axial length correlation would have been a good comparison.
Thank you.
Good morning everyone, I am here to present a paper on ocular manifestations in pregnancy-induced hypertension at a tertiary level hospital in Karnataka. Pregnancy-induced hypertension is a hypertensive disorder in pregnancy that occurs after 20 weeks of pregnancy in the absence of previously known hypertension. Preeclampsia and eclampsia are multisystem disorders that can involve end organs like kidneys, livers, eyes, hematopoietic system and placenta. Timely detection of changes in retinal vasculature can be a hint to the underlying changes in the vascular system of the various end organs of the human body, including placental circulation. Aim of the study was to evaluate the ocular manifestations in women affected by PIH presenting to a tertiary level hospital. This was a hospital-based cross-sectional study carried out for a period of 1 year. A total of 120 subjects diagnosed as cases of preeclampsia and eclampsia admitted to the eclampsia ward of the obstetric unit formed the study population. After taking history, a detailed ocular examination was done for all patients and the findings were noted. The mean age of the study population was from range 21 to 39 years. 62 had mild preeclampsia, 50 had severe preeclampsia and 8 had eclampsia. Ocular symptoms were present in 43, that is about 36% of participants. Blurring of vision was the commonest ocular symptom observed in the study population, followed by photopsia, diplopia, intermittent loss of vision, ocular pain and scotoma. Anterior segment findings like conjunctival congestion, lid edema and subconjunctival hemorrhage each accounted for 1.67% of the study population. Fundal changes were noted in 33.33% of cases. Arteriolar narrowing was the commonest fundal finding, followed by arteriovenous crossing changes. Also, cotton wool spots, retinal hemorrhages, papilledema, and choroidal infarcts were seen in few. Grade 1 hypertensive retinopathy was observed in 15% of participants. The mean systolic blood pressure and mean diastolic blood pressure were high among those with fundal changes compared to those without fundal changes. This was statistically significant. Proteinuria showed significant correlation with retinal changes. Our results contrast with the study done among the Tanzanian population at Muhimbili National Hospital, which found maximum cases of papilledema 28%, followed by retinal edema and cotton wool spots, arteriolar narrowing, and macular edema in 5.3%. Also, in the present study, we noticed that higher grades of proteinuria had more fundal involvement, which was in agreement with findings of studies done by Devaru et al. And Bhandari et al. In the present study, we witnessed 2 subjects with choroidal infarcts as some of the rare ocular complications of preeclampsia and eclampsia. Ocular involvement is quite often among pregnant women with preeclampsia and eclampsia, so it is very important for obstetricians to be aware of the various ocular conditions associated with pregnancy-induced hypertension. Early fundus screening in patients with PIH not only helps detect changes in the retina but also serves as a guide to detect similar changes in other end organs of the body, including placental circulation, greatly assisting a diagnosis and prompt treatment. These are my references.
Just to know, is the fundus finding, any of the fundus findings that you got, either choroidal infarct or sometimes subretinal fluid, grade 4 hypertensive retinopathy, was that an indication to terminate the pregnancy in your hospital?
No.
No. So they ask for frequent referrals, right?
Yes.
So how do they, correlate? Do they use those fundal findings for any of their management aspects?
Fundus findings. We can give references to nephrology if we find anything like that.
Okay.
No, when do you advise for any termination? At what stage?
That I don't know.
No, eclampsia generally goes
Yeah,
for a
yeah, you have
termination
to
of pregnancy. You have to
yeah.
terminate it. So if a person has got those kind of proteinuria plus high hypertension, you have to document the highest level of hypertension, because that won't be controlled with your medical management. And it has to go. Sometimes we used to be called middle of the night to say, look, give your fundus opinion and we'll terminate the pregnancy. And very, very important, you can have choroidal detachments in the same patients. So it's not just that you're seeing hemorrhages, so you have to terminate the pregnancy. Papilledema, all these things which are prime indicators for saying, look, I'm going to suggest termination of pregnancy, because most of them, they wait for crossing over of 32 weeks.
32 weeks, yeah.
You have to terminate the pregnancy after 32. If it's very little, then a lot of other considerations are there.
How common you do fundus examination after a patient is diagnosed with PIH? Like, do it in the first 6 weeks or 8 weeks or 12 weeks or 32 weeks? Like, how often?
And with PIH.
Thank you all the postgraduates for all the presentations. We just have a couple of announcements. So those of you who've registered for the wet lab, that's started. So at 10:30 sharp, the wet lab will be starting. So if any of you have registered for that, please proceed downstairs. The second announcement for all the delegates and all the postgraduates, the tea and the coffee has been arranged in the trade area, right adjacent to the main auditorium. So proceed there for a break, 11 to 12, you all can have tea over there, all right? Yes. And also, we'll take a 10-minute break and we'll start the next session. So which means that free paper session 2 is starting. So I request all the postgraduates who are presenting the cataract session to please come and upload their presentations, and please sit in that order so that, again, to save time, we just move from one to the other, all right?
Thank you, Shubha. Such an excellent presentation by all postgraduates. I'd like to thank all the postgraduates for doing such a nice presentation, which we learnt also from. Thank you.
We'd like to thank all the three judges on behalf of BOS for taking time out of their schedules and coming and judging the free paper session 1. As a token of the BOS appreciation, we'd like to give a small token. Thank you, Dr. Nanda. Thank you, Manju ma'am. Thank you, ma'am. Thank you, Dr. Shetty. Ma'am, I'll just take the mark sheets are here with me. You have all three? Yes. But it's starting with Dr. Uday ordinary Dr. Amita, Dr. Shivani, Uday ordinary boy. It's not, this is the session 3. No, no. I'll just see if it's there. Yeah, correct. Don't worry. Okay, so welcome back. Good morning. Please welcome your judges, Dr. Pratibha, Dr. Shweta, and Dr. Ramadevi. All the three of them will be judging the next two, your free paper session 2, which is cataract. So we'll start with the cataract sessions, and then we'll move on to orbit. Okay? All the very best to all the postgraduates. I welcome Dr. Ankita to start.
Good morning. So I'll be presenting the topic on ICL explantations with cataract surgeries. It is a case series of 3 cases. So implantable Collamer lens are posterior chamber phakic intraocular lenses which were FDA approved in 2005 for the correction of moderate to high myopia. In our case series, we evaluate the difficulties faced during the explantation of the different generations of ICLs following the development of cataract and their visual outcomes. So coming to my case 1. So case 1 was a 41-year-old female with a history of ICL implantation 20 years ago. On examination, the cornea was clear. There was pigment dispersion at the iris. A PI was present and rigid ICL was placed in situ. The lens changes showed a cataractus change of NS2 to 3 with cortical cataract was seen. So this patient was taken up for ICL explantation, and since it was a rigid ICL along with so an SICS was done for the cataract explantation, and after removing, this was the lens that was seen. Intraoperatively, scleral tunnel was recreated and the ICL was disengaged from the iris and was explanted, and a cataract surgery was performed. Post-operatively, the vision improved to 612. However, the patient had a -2 diopters of astigmatism, and the steroid course was given for a longer duration as there was a lot of iris manipulation done for this patient. Case 2, it was a 50-year-old male with a history of ICL implantation 10 years ago. On examination, the cornea was clear, a PI was present, a V4B lens was placed in situ, and the cataractus changes of NS1 to 2 with cortical cataract was seen. Post-operatively, the vision improved to 6/9 with a 1 diopter astigmatism. So as you can see in this, intraoperatively we didn't have to extend, since the V4B lens is actually a foldable lens, so we didn't have to extend the incision for too long. It was the incision was extended just to 3.2 millimeters, and the ICL was explanted. Case 3, a 36-year-old female with a history of ICL implantation 5 years ago. The patient had a foldable 3rd generation V4C ICL placed, and with cataract of NS3 was seen. Intraoperatively, using a 2.2 mm incision itself, we were able to remove the ICL, and a cataract surgery done, and IOL was implanted. The vision improved well to 6/6 post-operatively. So basically the three generations of ICL, the first one is the rigid lens which required a PI, and while removing we had to create a scleral tunnel. So the disadvantage with this ICL was that there was a lot of iris manipulation in itself, and apart from that there was a very high risk of astigmatism post ICL explantation. So these patients are not usually good for toric intraocular lens placements as well. Second generation, they have peripheral holes, but they don't have the central aqua pore. So the disadvantage of this is, again, we had to create a PI while implanting the ICL. So again, post-operatively, the iris manipulation chances of complications were high. And the third generation, which is the presently and most commonly used ICL, was the one with the central aqua pore for controlling the IOP. It was flexible and can be removed from 2.8 to 2.2 mm incisions. Discussion. So there are multiple reasons which warrant ICL explantations. The most common one being the reduced endothelial cell count, cataract or high IOP. In our case series, we demonstrate the various difficulties that we faced while explanting the ICLs at different generations and their post-operative complications that we'll see. To conclude, newer generations of ICL have better visual outcomes. The explantations when required during cataract surgery is easier and less traumatizing, and even for cataract surgery outcomes are better with newer generation ICL. Thank you.
Hello. Was there a difference in the type of cataract or the density of cataract, anything among these things?
Ma'am, actually all of them were just nuclear sclerosis and maybe a little peripheral cataract, peripheral cortical cataracts, ma'am. There was no different type of cataract that developed, because even the duration post-ICL was actually quite long, ma'am. So an anterior subcapsular cataract was not seen in any of the patients.
But your third patient is really young. She's 36-year-old. What caused cataract in that patient? Because you used newer generation ICL, right, with central aqua pore.
Ma'am, I think it's the continuous steroid use maybe that could have led to the cataract changes, because the vault height was normal in the patient. There was no touch during the surgery, because all the ICL implantations and explantations were done by the same surgeon.
Implantation as well.
The last patient implantation also was done by the same surgeon.
Thank you.
All the three series, no? It is bilateral or unilateral?
Unilateral, ma'am.
Okay, what about the other eye in all the three cases?
Ma'am, in the second case, the other eye had an ICL, but there was no cataract that got operated. The other two, there was no surgery done. There was no ICL placed in the other eye, ma'am. It was just done for one eye.
Okay.
Good morning, everyone. My topic for today's presentation is analysis of objective scattering index in bifocal versus trifocal intraocular lenses. So, high definition HD analyzer, it is an instrument which is based on the double pass technique, which is developed by Visumetrics. So, the components measured by HD analyzer are OSI, tear film stability, depth of focus, and best focus. The comparison between this multifocal and trifocal intraocular lenses, it will help in assessing the quality and the quantity of vision in the correction of high refractive errors. And objective scattering index will be useful in comparing the visual outcomes and the diffraction of light in these type of lenses. So 80 eyes were studied, that is 40 eyes in each of the two types of lenses with age more than 45 years of age undergoing cataract surgery with Technis multifocal IOL, Zeiss Atlesa 809M model IOL, and in trifocal Technis Synergy IOL and Zeiss Atlesa 839MP model IOL were selected, and the examination included slit lamp biomicroscopy, dilated fundus evaluation, uncorrected distance visual acuity, and uncorrected near visual acuity, and OSI was measured using HD analyzer instrument on post-op day 1 and day 30. So we found that the OSI in cases of multifocal IOL on post-op day 1 was 4.17, and in trifocal on day 1 it was 4.51, but on day 30 multifocal IOLs were found to have lesser OSI of 1.88 and trifocal were found to have higher OSI as compared to the multifocal IOL, which was 2.78. And there was no comparable difference found between uncorrected distance and near visual acuity in both these types of lenses. So this OSI analysis in between these two types of lenses following cataract surgery, it will offer important information on their optical characteristics and potential clinical applications. So in our study, these multifocal lenses outperform the trifocal lenses in terms of optical quality as indicated by the lower OSI values according to our study. So the distance and near visual acuity were not comparable in between these two types of lenses, but intermediate visual acuity will be better in trifocal IOLs, which was not analyzed in our study. So we conclude that IOL designs which come in a variety of forms today, each with its unique restrictions and advantages. So patients with pre-existing retinal dystrophies, retinal disorders, or any neurological disorders, etc., will probably tolerate premium IOLs with lesser OSI better as compared to IOLs with higher OSI. These are my references. Thank you, everyone.
If you are comparing clinically these things, so what were the problems they faced?
Ma'am, on comparing, like the visual outcome was same in between.
No,
the
no,
two.
no. I'm asking about symptoms.
Patients didn't had, not many patients had any symptoms post-op.
Like what?
Like
Halos,
glare
glare, I'm
and
asking.
halos.
They didn't have or they had less?
They had very less, ma'am. Very less percentage of patients had these symptoms.
Both or which one?
Mostly in trifocal IOLs, patient had this glare and halo symptoms, ma'am.
More?
Yes. Thank you, ma'am.
Good morning, everyone. My name is Dr. Madeja. I'll be talking about glycemic control and its need in cataract surgery. Individuals with diabetes have an increased risk of cataract, and visual outcomes after cataract surgery were reported to be less favorable in presence of diabetes. And it carries a higher risk of both intraoperative and postoperative complications compared to non-diabetic patients due to pre-existing diabetic retinopathy and macular edema. Cataract surgery may lead to rapid progression of the retinopathy changes, precipitate vitreous hemorrhage, and induce iris neovascularization, and ultimately lead to decrease of and loss of vision post-op due to inflammatory cytokines in the eye. In this study, we aim to correlate the glycemic control to visual outcome and its complications in diabetes following cataract surgery. This retrospective analytical hospital study was conducted on 300 cataract patients with diabetes in fulfilling the inclusion criteria after obtaining approval from the ethics committee. The medical records of diabetic patients who underwent cataract surgery from Jan 2023 and to December 23 were reviewed and analyzed. Patients with corneal pathologies, vitreous hemorrhage, etc. were excluded. Coming to results, in diabetics with good glycemic control, that is less than 6.5% HbA1c, 89% of them had a visual acuity better than 618 post-operatively. And in poorly controlled diabetics, that is glycemic index more than 6.5, 66% had a visual acuity better than 618, and the rest had a visual acuity less than 624, and 18% had a visual acuity less than 660. Out of the 300 patients, 42 patients had retinopathy changes pre-operatively, and 136 patients, the fundus could not be analyzed because of dense cataract. PC rent occurred in 14 patients, and 1 patient ended up with endophthalmitis. 31 of the patients post-operatively had to undergo PRP to reduce the progression of DR, and 24 patients were given anti-VEGF injections. Coming to discussion, there was no progression of DR found in some studies, where Squirrel et al. Noted that diabetic retinopathy progression following cataract surgery in patients with increased glycated hemoglobin levels. Delaying surgery until later stages may lead to worse visual outcomes, especially when the diabetic macular edema cannot be identified or treated adequately prior to cataract surgery. Performing cataract surgery before the lens opacifies before lens opacities obscure macular assessment, reduce the risk of diabetic macular edema, and may significantly improve visual outcomes. In conclusion, I would like to say the severity of retinopathy and the presence of diabetic macular edema and pure preoperative visual acuity are recognized as a risk factor for poorer postoperative visual acuity following cataract surgery. Intravitreal steroids may be considered during or after cataract surgery in eyes with DME for optimal visual outcomes. These are my references. Thank you.
And case was with the endophthalmitis, no? What was the diabetic control status? in
It
that
was
patient?
poor, ma'am. His HbA1c was around 11.3.
Then still it was taken for
No, we
cataract
were
surgery?
for the sake of the surgery, we reduced his sugars for that moment, because he had a lot of diabetic retinopathy changes, and the VR consultant told us they needed clear media to proceed further with laser or any.
Okay. The intravitreal injections were given, no? For what reason? Only for DME or anything else?
Yes, ma'am, only for
Okay.
What was your objective and what did you conclude?
Ma'am, it is because we are from a tertiary center, ma'am. Like most of the patients who don't have the idea about diabetic control and all. So if we reject these patients with high HbA1c, they will end up losing their vision ultimately. And if we actually operate on them, irrespective of their glycemic control, there is at least a chance of them, few of them might have good vision.
Good morning once again. So my second topic is early visual outcomes with implantation of the new enhanced monofocal IOL. So as we know, the IOLs have progressed from the spherical monofocal to aspheric monofocal to simultaneous vision lenses. So in the simultaneous vision lenses, there are the multifocal lenses, the trifocal lenses, the EDOF lenses, and what is newly come out, the enhanced monofocal IOLs. So the mechanism used by the extended depth of focus in EDOF lens include a spherical aberration, pinhole effect, and a secondary astigmatism. The lens that we saw, the Vivinex Impress, is a single piece in enhanced monofocal IOL crafted from glistening free hydrophobic acrylate. It is aspheric, its aspheric optic design facilitates an extended depth of focus, specifically augmenting the intermediate range of vision. This IOL combines a standard aspheric and an even order aspheric surface designed with a microscopic angulations, which help in the extended depth of focus. So this study seeks to evaluate the visual outcomes and quality of vision of this new enhanced monofocal IOL by measuring the visual acuity, the defocus curve, reading speeds, aberrations, objective scatter index, and other relevant parameters over a period of 3 months. So the aim of the study is to evaluate the visual outcomes of a new enhanced monofocal IOLs. Study design, it's a prospective interventional study. Sample size was 40 eyes. The mean age of the patients was 64.9 plus or minus 10 years. The total, in the total eyes, that's 40, 19 were males and 11 were females. Methodology on POD 15, 1 month and 3 months, the uncorrected distance visual acuity, corrected distance visual acuity, uncorrected intermediate visual acuity, and uncorrected near visual acuity was evaluated. So the results, so the vision, we saw that 95% of the patients at the end of 3 months had a visual acuity of 6/6 or 0 on logMAR, and 100% of them were within the 6/9 margin. The intermediate visual acuity was 6/7.5 to 6/9 in almost all patients at 66 centimeters. That is the intermediate distance that we have taken into account. The Salzburg reading index at 66 centimeters, the average reading index was 170 words, plus or minus 66.6 words per minute, and the objective scatter index at 1 month was seen to be 3.11, which reduced at 3 months to 1.68. coming to discussions, the standard cataract surgery has high success rate with conventional monofocal IOLs, even though they provide excellent visual acuity they provide that only for a fixed focus distance. Daily tasks have changed, and now now people also require good vision for intermediate range of focus, such as manufacturers. Such manufacturers have studied a new solution to overcome this. The extended depth of focus is an emerging technology that is designed to improve this vision. In our study, we saw that the uncorrected intermediate visual acuity was similar and was consistent to a lot of other studies, such as the ones published by the Menusi et al. And also the ones published by Victoria Pai et al. However, having said that, there are very few studies done on the lens that we have studied, that is the Hoya Vivinex Impress. There is only one other study which has been done which shows similar results to us. So there is a requirement for more studies to prove the efficacy. Conclusion. From our study, we can conclude that the Hoya Impress is a safe and effective lens which has excellent intermediate vision.
Did they all need near vision glasses?
They were around N8, most of them, ma'am.
So they all needed near vision.
Yes, but for intermediate and for distance, they were N6.
Driving?
Driving, they were comfortable.
Were they
ma'am.
comfortable for driving? Did
Yes,
you
ma'am.
assess that part?
Yes, ma'am. There were no glares, no halos, nothing, and even night driving, they were very comfortable with, ma'am.
How was the intermediate vision assist?
Ma'am, we used the we used the chart at 66 centimeters we had kept, ma'am. So that we get the chart in the Hoya company itself had provided us the chart to assess at 66 centimeters, which has the tape which measures at 66, and we use that to assess the Snellen's visual acuity.
So this lens falls under what category? Extended depth of focus, is it?
It's a kind of extended depth of focus, but it's a newer technology which is the enhanced monofocal. So there is another one, the Technis iHands. So these two basically tell us that they have lesser halos because there is lesser diffraction of light in enhanced monofocals. That's the present concept that they are.
What reduced OSI at 3 months? Why is it reducing?
Ma'am, because the patient is getting more acclimatized to it, and they were able to read it. Thank you, ma'am.
Good morning, myself Dr. Atmiya. I will be presenting on prevalence and risk factors for cataract in type 2 diabetes mellitus. The prevalence of type 2 diabetes mellitus and its associated complications is increasing at an alarming rate in India. Cataract is considered as a major cause of visual impairment in diabetic patients, as the incidence and progression of the cataract is high among the diabetics. Cataract occurs at early age and it's 2 to 5 times more frequent in diabetics. This study aims to estimate the prevalence of cataract and its subtypes in patients with type 2 diabetes mellitus and possible risk factors associated with it. The study was conducted on 450 patients with type 2 diabetes mellitus attending the OPD. Inclusion criteria: patients with type 2 diabetes mellitus aged more than 40 years, 40 and above, diagnosed as per WHO criteria. Exclusion criteria: patients who are less than 40 years, patients with type 1 diabetes, pregnant and lactating women, immunocompromised patient, diabetic patients who had undergone bilateral cataract surgery, and patient with ocular pathologies like uveitis, myopia and retinal detachment. Results: out of 450 patients with type 2 diabetes enrolled in our study, 292 patients had a cataract and 155 had no cataract. 144 were male among 292 and 148 were females. Prevalence of cataract in type 2 diabetes was 64.88%, and 65 cases were newly detected, and 227 cases had long-standing diabetes. Mixed cataract was seen in 70.52% and monotype cataract was seen in 29.48 patients. The combination of nuclear, cortical and posterior subcapsular cataract had a highest incidence with 42.26. Among the monotype cataract, 68.28% of the patient had a cortical cataract. Nearly 2/3 of the diabetic population showed evidence of cataract. increasing age, female sex, longer duration of diabetes, family history of diabetics on OHA agents, poor glycemic control were risk factor for the development of cataract. Modulation of these variables may delay the occurrence of cataract in the population of type 2 diabetes mellitus. Identifying this cause and managing the same with a surgical treatment would be an important step in reducing the economic burden, particularly among the working age group in the population with diabetes. Thank you.
What was different in your study from the normal available data?
No, ma'am, it was like we had seen more mixed cataracts than the monotype cataracts. There was not like any peculiar feature that we had observed. It was the data we had given
Comparative.
comparative data.
PSC is more common, right, according to the...
Nuclear cataracts are more common, ma'am, monotypes. But here, the mixed cataract, we had nuclear, cortical, and posterior subcapsular cataract.
You didn't assess the duration of diabetes and...
Yeah, ma'am. Newly diagnosed diabetes was like out of 292 patients, 65 were newly diagnosed diabetes.
They had
patients.
more cataract, less cataract, like that? Did you have any?
No, ma'am. That assessment was not done. Usually, the majority were like old diabetics patients, long-standing diabetic patients, and with the family histories.
Good morning everyone, myself Dr. Sadhvini. My topic of discussion today is comparison of intraoperative phacoenergy and post-op endothelial cell density with and without the use of MyLoop for hard cataracts. There was no financial interest in promoting any brands here. So the common complications that we all encounter while managing a hard cataract are wound burns, post-op inflammation, zonular dialysis, posterior capsular rent, nucleus drop, and corneal edema. There are many methods to manage it like SICS, ECC, femtosecond laser assisted cataract surgery. Yet another way to manage hard cataract is by the use of this micro-interventional lens fragmentation device called MyLoop, which is micro-thin and super elastic. It is a self-expanding nitinol filament technology which consumes zero energy and gives full thickness lens fragmentation for any grade of cataract. It uses centripetal force in cracking the nucleus, has a short learning curve, and also is zonula friendly. The aim of the study was to compare intraoperative cumulative dissipated energy and equivalent average ultrasound time between both the groups and to estimate pre and post-operative endothelial cell density between the groups. It is a prospective study which included cataract grade of 4 or more according to LOCS grade of classification. And the exclusion criteria were uncooperative patients and patients that had to be converted to small incision cataract surgery or extracapsular cataract surgery, and compromised cornea and pupil dilatation which is less than 6 mm. A sample size of 50 eyes were included and randomized into two groups, that is phaco only and phaco with MyLoop group. A single experienced surgeon operated on all the eyes using the Centurion Vision system with the same energy and fluidics parameters. Intraoperatively, mean CDE and equivalent average ultrasound power was noted. And post-operatively, on day 1 and 6 months, mean endothelial cell density was compared between both the groups. So these were the energy parameters that was obtained from each case. And on post-op day 1, corneal edema was graded based on the number of the Descemet's folds seen on slit lamp examination. Coming to results, the corrected distant visual acuity in both groups at 6 months was logMAR minus 0.020 in both the groups, and there was no significant difference between the two. Grade 3 corneal edema was seen in 3.3% of phaco group and 0% of MyLoop group. Mean CDE consumed in phaco group was 19.42 and in MyLoop group was 15.91. Mean equivalent average ultrasound power used was 25.86 in phaco group and 20.82 in MyLoop group, which was statistically significant. Coming to endothelial cell density, on post-op 1 month, phaco group showed a mean endothelial cell density of 2089, whereas MyLoop group showed a mean endothelial cell density of 2360, which was statistically significant. On post-op 6 months, the phaco group showed a mean ECD of 2156 and MyLoop group showed a mean ECD of 2438, which was statistically significant. The percentage of endothelial cell loss was 11.8% at 6 months in MyLoop group as opposed to 19.7% in phaco group. Coming to discussion, Edward Hu et al. In their study reported that the CDE was 21% less used in MyLoop group. Sancho et al. In their study reported that CDE was 53% less in MyLoop group, but they did not report any significant difference between the endothelial cell loss. William F. et al. In their study reported CDE usage of 16% less, whereas our study reported 18% less usage of CDE in MyLoop group and 8% less endothelial cell loss in MyLoop group. To conclude with, MyLoop may be a useful tool to assist in the management of brown cataracts. It leads to less ultrasound usage and less endothelial cell loss compared to routine phacoemulsification in brown cataracts. However, further data is required to establish
When was that MyLoop introduced? Like after hydro?
Yes, ma'am. After hydrodissection, MyLoop was introduced, and then the nucleus was cleaved into two hemispheres.
Only two?
Yes, yes, ma'am.
Okay.
You could have done more fragments and used lesser energy, no?
Yes, ma'am. But we chose to do 2 fragments uniformly for all the cases.
Have you compared with any study where plain small incision cataract surgery was done for these hard brown cataracts? Have you?
No, ma'am.
No, have you come across or did some research on it?
No, ma'am, not sure about. Just the phaco.
The endothelial cell loss and with this your newer technique and...
with SICS and phaco.
Yes, yes. No, I am asking this because plain SICS, except for the bigger section.
Yes, ma'am.
If you use a high viscoelastic, high density viscoelastic, maybe the endothelial cell loss is
lesser. No, ma'am, I did not come across it.
Yeah, you should have some data, right?
Yes, ma'am.
So that many people may not have access, or many people, I mean, it's a research thing and newer thing. We did learn something, but you should know that also, so that it should not be lesser technology.
Thank you.
Good morning, one and all. I am Dr. Gautami. I am today presenting a study on visual outcome following cataract extraction and with IOL implantation in a patient with high axial myopia. We know myopia is one of the most prevalent disorders of the eye causing visual impairment, and which is corrected by spectacle, contact lenses and surgical means like lens extraction with IOL implantation. High myopia is considered when power is more than or equal to -6 diopter or axial length more than 26 mm. And cataract surgery is done in these patients, and it accounts to about 30% of total cataract surgeries in a tertiary care hospital. And the outcomes of these patients, to know prior the surgery, is important for the patient counseling. The main objective of my study is to know the visual outcomes post cataract extraction with IOL implantation in these patients with high myopia, and to assess pre and intraoperative complication, and to compare with the SICS and phaco technique. Methodology includes this: the prospective observational study including 55 eyes, and the patients with more than 26 mm of axial length with the pre-senile cataract or senile cataract is included in this study. With a complete ophthalmic evaluation and IOL calculation, patient was posted for the surgical interventions like that's a cataract surgery, either SICS or phacoemulsification, and outcomes were measured at 4 weeks post-operative, and the intra and post-operative complications were assessed. To know the results, among the 55 eyes, 28 patients are male, 28 are male and 27 are female. In this, 33 patients were immature cataract and 22 patients were mature cataract. On the pre-op visual acuity, less than 6/16, 96% of the patient, and more than 6/16, 3% of the patient. And coming to the axial length distribution, the axial length between 26 to 28 mm, 31 patients were there. 19 patients in 28.1 to 32 mm, and more than 32 mm, 5 patients. And the pre-op complications were noted in 40% of the patient. These patients underwent either phaco or SICS. Among them, 19 patients underwent phaco with foldable IOL, and 32 patients underwent SICS with rigid IOL. Among them, 4 underwent SICS with iris claw or rigid lens in the circle. And the visual acuity are assessed after 1 month post cataract surgery. In this, the 1 month post cataract surgery, including phaco SICS and the SICS with rigid claw include 36 patients had a vision between 6 by 6 to 6 by 18, and the remaining patient had less than 6 by 18. It accounts to about 65.45%. And the visual acuity were assessed for, in the patients who had underwent SICS with PCIOL. Among them, 48.48% of the patient had vision of 6 by 6 to 6 by 18. And the patients who underwent phaco with foldable IOL, that is 19 patients, among them 18 patients had vision between 6 by 6 to 6 by 18, and it accounts to about 94.73%. And we analyzed the comparison between the post-operative vision in respect to the axial length. The axial length between 26 to 28% had a better visual outcome even in the post-op day 1 and post-op day 30, and it is with a p-value of 0.004, which is statistically significant. It is clinically also significant. And similarly, the visual acuity was analyzed in terms with the complication. The patients who had 26 to 28 mm of axial length had a lesser intra pre-op complication compared to the higher axial length patients. And our study was comparable with the studies which was done by Shanghai High Myopia Group study, where they found that the visual acuity in a high myopia with a higher axial length had a poorer outcome compared to the less axial length. And even the Praveen MR study, where the nuclear cataract was more prevalent in those group. The take-home message, in this study, we are assessing the visual outcome, and the patient with 26 to 28 group had a good visual outcome compared to the higher axial length group, which is important to counsel the patient pre-op regarding their visual outcome.
How the patients were categorized, like who will undergo SICS, who?
Non-randomized study based on their nuclear grading and the IOL availability, because the minus power lenses we had only rigid power. So post-op only it was categorized as SICS and phaco. Pre-op randomization is not done.
Okay. What about their retina status? Like they are all high myopes, no? How was the retina?
Among 55 eyes, around 25 to 26 patients have a posterior staphyloma also, and these patients had poor vision post-op. That was the limitation, that pre-op OCT was not done because of the poor vision, and I planned for the during the follow-up OCT to know whether the vision is poor because of the retinal changes or because of intra-op and lens-related things.
What anesthesia you did?
Local anesthesia, ma'am. But few of them which are very high myopes in 28 and 32 groups, we have given subtenons, and few are done in topical also, phaco.
IOL calculation formula, which formula?
We have used SRK-T2 formula.
And what are the intra-op complications that you encountered?
Around 6 patients had zonular dehiscence, 3 patients had PC rent. For them, iris claw was placed, and few more had 3 to 4 clock hours of zonular dehiscence. For them, CTR was placed, and the similar foldable lens was placed in the bag itself.
Good morning, everyone. So I'll be talking about the clinical profile of cataract patients with asteroid hyalosis in a tertiary care center, a retrospective study. So coming to the introduction, asteroid hyalosis is characterized by the presence of small yellow-white spherical particles scattered randomly or arranged in chains or sheets throughout the vitreous, composed of lipid, calcium, phosphate complexes. They exhibit a smooth spherical morphology moving in tandem during head or eye movement, typically noticed by chance in individuals aged 60 to 65 years, affecting one eye with a global prevalence of 0.3 to 2%. Many patients in the age group, those who had asteroid hyalosis, may also have both asteroid hyalosis and cataract. So it was a retrospective study conducted on 45 cataract patients fulfilling the inclusion criteria after obtaining approval from the IEC. the medical records of cataract patients with asteroid halosis who underwent cataract surgery from January 2023 to June 2024 was reviewed and analyzed. Patients with corneal pathologies, retinal pathologies, vitreous hemorrhage, and other ocular conditions which causes decreased vision were excluded. Coming to the results, majority of the subjects were in the age group of 65 to 75 years, and out of 45, 25 were female and 20 were male. And coming to the risk factors, 22.2 were hypertensives and 28.9% had type 2 diabetes. And the significant investigations we found was HbA1c, which had a mean value of 7.53. Coming to the visual acuity, comparing the pre-op and the post-op vision after 1 week and after 1 month after surgery, the data was statistically significant. And the complications, the most common which we seen was the striate keratopathy, and which was 13 patients. And coming to the axial length and the post-op refraction, there was a negative correlation. Coming to the discussion, unlike the gender predominance, the age stratified data from the Yonsei study and the Beaver Dam Eye study were in line with our results. Also, the association of asteroid halosis with diabetes mellitus in our study is in line with the positive association reported in these studies. As the increased permeability of basal membranes in diabetic eyes is likely to be the source of phospholipid and calcium needed for the asteroid formation, testing for diabetes should be considered in patients with asteroid halosis. And our data was showed that many patients with asteroid halosis were associated with hyperopia as observed by the Begren and the co-workers. So I would like to conclude by saying the limitations of our study, which included a small number of cases, and we did not consider the lens thickness and central corneal thickness, and we couldn't confirm the Beaver Dam Eye study findings that suggested associations between asteroid halosis and higher body mass index, history of gout, and alcohol consumption. A-scan may display inaccurately short AL due to axial length due to the echoes from the asteroid bodies. Comparing the asteroid halo as axial length of the fellow eye can provide useful clarification. The reflections from asteroid bodies can obstruct the view of the posterior capsule. So silicon IOL should be considered, should be avoided due to the potential deposition of calcium and phosphorus from asteroid bodies on the posterior lens surface. So the take-home message will be the manual biometry is more better than the automated biometry in these cases. And these are my references. Thank you.
So the cases with asteroid halosis and normalize, anything you have compared, or?
Ma'am, the axial length was compared with
Vision.
Vision, post-operative only the after the cataract surgery, that eyes were
Only as patients with asteroid halosis?
yes, ma'am.
Does it affect normally?
It's very rare to affect the visual outcome in asteroid halosis unless they had complications which may require vitrectomy later stages.
Okay.
Good morning, everyone. Myself, Dr. Nagasspandana K. I'll be presenting on surgical outcomes of retropupillary fixated iris claw lens in complicated cataract surgery. FAK is commonly the result of complications arising from the cataract surgery. So the loss of posterior capsule or the ciliary zonules results in inadequate support for the implantation of a standard posterior chamber IOL. This is an image showing iris claw IOL. So we go ahead with secondary IOL implantation in cases of loss of capsular support that includes anterior chamber IOL, scleral fixating IOLs as well as iris claw IOLs. The disadvantages with anterior chamber IOLs are corneal decompensation, whereas this scleral fixating IOLs, there can be suture-related complications as well as retinal detachment. So we go ahead with iris claw IOLs. In that, there can be anterior fixation of iris claw IOL as well as retropupillary fixation of iris claw IOLs. But one of the disadvantage with anterior fixation of iris claw IOL is corneal decompensation. So, as iris claw IOL is attached to the mid-periphery of the iris, the complications related to the size of the IOL and damage to the angle of anterior chamber and the root of the iris can be avoided with retropupillary fixation of iris claw IOL. It's a prospective interventional study which was conducted at KIMS Hospital, Hubli for a period of 6 months. It includes 20 FAK eyes with inadequate capsular support. All the complicated cataract surgeries with PC rupture and zonular dialysis were included in this study, and patients with uveitis, glaucoma and aniridia were excluded. Preoperatively, uncorrected visual acuity, best corrected visual acuity and slit lamp examination to visualize the anterior segment, keratometry and A-scan biometry was also done, and IOP measurement was done by Goldmann supplementation tonometer and fundus examination. Post-operatively, we evaluated best corrected visual acuity, intraocular pressure, anterior chamber reaction and shape of the pupil. Coming to the results, iris claw IOL was implanted in the second sitting, that is second IOL implantation was done in all those patients with PC rupture. This is an analysis showing the logmar vision with pre-op and post-op visual acuity. Pre-op, all this mean average of all the cases was logmar 1, that is around 6/60 according to Snellen's. On post-op day 1, visual acuity was around 624, that is 0.6 in logmar. And post-op 1 month, it was 0.4, around 612 visual acuity. And coming to, in 75% of the cases, all these patients were having round pupil, whereas in 25% they were having oval pupil. Coming to intraocular pressure changes, pre-operatively, all these cases were having around 16 intraocular pressure. On post-op day 1, there was slight rise in IOP to around 18, and post-op day 15 and day 30, the pressures have reduced. Secondary IOL implantation in the absence of adequate PC support is challenging for cataract surgeons. The anterior insertion of the iris claw IOL puts corneal endothelium at risk. So, iris tissue thickness should be adequate for enclavation of this iris claw IOL, and a blunt instrument like a Sinskey hook can be used to reduce the perforation of the iris. So, retropupillary insertion of iris claw IOL protects the endothelium from the IOL, and this IOL is more positioned near the nodal point without the use of any extra sutures or glue. And post-op, we have given topical antibiotic and steroids. Conclude, retropupillary iris claw IOL implantation in aphakic eyes without adequate capsular support is a safe, predictable and effective procedure with a good visual outcome and less intra-op and post-op complications. These are my references. Thank you.
You said all are secondary IOLs, no?
Yes.
Like not in the same
Not
setting.
same setting.
Okay. How? What is the duration of surgery and then secondary IOL
Around
surgery?
15 days, ma'am.
Is it the same for all?
No, it varied with cases. Like it depends. Like what was the vitreous loss, like following PC rupture in the. If there's so much of inflammation, we used to wait for so long. Otherwise, we would go ahead with 15 days.
15 days.
Yes.
Was the pre-op visual acuity, refraction and all assessed, and did the outcome match with your aphakic refraction you do, right?
Yes, ma'am.
Pre-op.
Yes, ma'am.
Is the outcome matching with that refraction?
Yes,
The
ma'am.
visual outcome, I mean.
Yes, ma'am.
Was it 612 pre-op also when you do with refraction?
Yes, ma'am. With plus lens, when we do, it's same.
Same.
Yes.
None of them improved beyond 612.
No. Thank you.
No complications? Have you assessed the complications post-operative?
Yes, ma'am. Post-op, they were having corneal edema, and post-op on day 1, we were seeing IOP spikes also, ma'am. Then apart from that, antechamber inflammation, like almost grade 2 to grade 3 in few cases.
For how many days it was assessed?
Like for 1 month follow.
1 month.
Yes, ma'am.
So lead complications, nothing was there.
Apart from
CME,
this,
nothing.
No, ma'am.
No.
Thank you.
Good morning, one and all present here. My name is Dr. Vaibhavi. I'm going to present on the topic Through the Eyes of Autism, Ectopia lentis. So, autism spectrum disorder is a behavioral developmental disorder whose etiology is lesser known. 10% of the cases have a genetic syndrome. Ophthalmic evaluation helps to provide clues to aid in ASD workup. So, I'm presenting a retrospective case series of 2 children with ASD who had come for a regular ophthalmic evaluation. So, the first image is the child with the homocystinuria, and when we evaluated him, it was found to have an inferonasal subluxation. And the second picture is of a second patient who had Marfanoid features and had a superotemporal subluxation of lens. So coming to the details, so case 1 was a 6.5-year-old male child with binocular visual acuity of 6/24. Anterior segment finding showed bilateral microspherophakia with inferior subluxation of lens, which prompted us to send for blood investigation, which showed high serum homocysteine level, and a genetic sequencing was done for the child, which showed mutation present in homocystinuria. That is mutation in chromosome 21, CBS gene. Case 2 is another an 8-year-old male child with binocular visual acuity of 6/18. His anterior segment findings were suggestive of superotemporal lens subluxation, and this child underwent genetic testing which was positive for 15q deletion suggestive of Marfan syndrome. So the ophthalmic evaluation basically pointed out ectopia lentis, which prompted the child to undergo genetic testing. This helps to give us clue for helping in ASD workup. These 2 case series helped us find out for the genetic testing, and which was positive for homocystinuria and Marfan syndrome respectively. This helped us find links of ASD with a genetic condition which can also cause developmental and behavioral abnormality. There was a case report done in Nigeria which showed links of ASD and Marfan syndrome, but no study so far conducted has shown links of ASD with homocystinuria, which can also be misleading, as homocystinuria is also known to cause developmental and behavioral abnormalities. So the above mentioned cases emphasizes the need of thorough clinical evaluation of all systems, including ophthalmic evaluation, which can act as an aid to providing clues to the possible etiological factors of ASD. This helps in developing targeted intervention strategy for better quality of life. These are my references. Thank you.
Were the kids referred to Ophthal from pediatrics?
Yes, ma'am. Yes, ma'am.
Genetic testing was done after this.
Yes, ma'am.
Okay.
Genetic.
Other clinical features were not like supporting this.
Ma'am, one child, the second case, had tall stature and had elongated limbs and all. They were suspecting Marfan syndrome only, so they just sent for a regular checkup, which was found. The first child did not have any symptoms. Since he was a kid, since 2 years only, he was following up for pediatrics, and they were evaluating as autism only. But later, when he was not having reduced social interaction, he was having reduced eye contact with people. So they sent for an eye evaluation. So there we found out that he has high myopia and for testing. Thank you.
Good morning, everyone. My topic is a study to evaluate visual outcome and complication in the pseudoexplanatory eyes after the small incision cataract surgery. Coming to the introduction, as we all know, pseudoexplanation is the most common cause for surgically small pupil. It's an age-related genetically related fibrillopathy characterized by gradual accumulation and deposition of abnormal fibrillar extracellular material, which more of protein gags surrounded by proteins. Complication during cataract surgery like posterior capsular rupture, zonular dialysis, hyphema, and insufficiently dilated pupil. The aim of the study is to analyze the visual outcome, post-operative complications after the small incision cataract surgery, patient with the cataract with pseudoexfoliation. So methodology, inclusion criteria is the patient who are having pseudoexfoliation with age more than 50 years. Exclusion criteria like traumatic cataract, complicated cataract, uveitic cataract, any posterior segment pathology, or corneal scars. This is the prospective study, prospective observational study conducted in the 30 eyes, presenting with the cataract with pseudoexfoliation and undergoing small incision cataract surgery with a PMMA intraocular lens implanted at the KIMS Hubli. Pre-op examination includes slit lamp examination to note the cornea, anterior chamber depth, lens status, grading of the cataract, and the posterior segment pathology with 90-day biomolecular examination. If it is a mature cataract or brown cataract where we can't examine the posterior segment, B scan has been done. And the Goldman operation tonometry to evaluate the IOP. Results are all 30 patients had pseudoexfoliate material on the pupillary border and on the peripheral anterior capsule. So result shows the 66.6, around 20 patients had corneal edema, on the around 5 patients has decentered IOL, 2 were irregular pupil, and 1 was fibrinously uveitis is there. And the logmar vision is pre-op at around 1 and post-op at day 1 it was 0.4 corresponding 615 and post-op at 1 month it is 0.3 corresponding 612. At coming to discussion at first month and third month post-operatively, the corneal complication have been significantly resolved. The intraocular pressure gradually decreases during each visit from the pre-op value, and none of the cases required anti-glaucoma medication after a week. Coming to the conclusion, good post-operative visual outcome can be achieved with the small incision cataract surgery by careful pre-op evaluation of the risk factor and surgical plan, timely and adequate surgical modifications such as sphincterotomy depending on the rigidity of the pupil and the level of mydriasis to reduce intraoperative complication. These are my references.
Post-operatively, how was the follow-up?
On the day 1, first week, 1 month and 3rd month.
Okay, 1 week and 1 month and okay. 1 week you have not mentioned. Day 1 and 1 month. Okay. Pre-operatively, none of them have IOP SPY?
No, ma'am. No one has.
Okay. Angle assessment?
Gonioscopy has been done, ma'am, pre-operatively.
None of them had narrow angles in this? Or you didn't take narrow angles? No, there is chance of narrow angles in pseudoexfoliation, anterior subluxation, zonular weakness.
Yeah, it is there.
Those things.
Whatever we have selected like that, in that it is not there.
Maybe you didn't choose any narrow angles. Did you exclude or?
No, we didn't exclude, ma'am. Whatever patient has come for routine OPD, like that we done.
Gonio was normal. Open.
Yes,
Open.
Open angle.
Oh.
Disc changes, none of them had. Any disc changes?
That has been, some has like, cupping was there, ma'am, 0.4, 0.5, but that was with healthy NRR, so didn't go ahead with any other.
Why so many patients had corneal edema post-operatively?
Sorry, ma'am?
So many patients, 66% of patients had corneal edema.
Ma'am, that is, might be iatrogenic, ma'am, because long duration for the surgery, surgically small pupil. Thank you.
A very good afternoon, everyone. I'm Dr. Aparna. My topic is orbital inflammatory disease, no longer a puzzle. To study the clinical features and the outcome of various treatment modalities for orbital inflammatory disease with protocol-based management. Introduction to OID. Orbital inflammation accounts for 6% of the diseases involving the orbit. It is a diagnosis of exclusion. It is one of the most misdiagnosed orbital diseases. Usually, it is suboptimally treated with serial high doses of oral steroids, which has long-term adverse effects and also leads to non-resolution of the disease. Pseudotumor is an obsolete term which does not mean anything now. This study is done by 20 patients who are attending the ophthalmology and rheumatology OPD in a tertiary eye care center in Bangalore. It's an observational study with a duration from September 23 to June 24. The age of the patient is between 18 to 80. The exclusion criteria includes patients suspected to have malignancy and other infectious conditions of the eye. So the patients were subjected to history and clinical examination. Anterior and posterior segment examination was done. The relevant investigations in the form of blood tests and imaging modalities was advised, which was followed by early biopsy, followed by short post-operative course of steroids and early induction of immunomodulation. The results. So, out of 20 patients studied, 18 had unilateral presentation. So, this shows that OID is most commonly unilateral. The common comorbidities that the patients had was diabetes, followed by hypertension and hypothyroidism. So, the common clinical features that the patient presented were swelling around the eyelids, followed by proptosis. Some patients had pain in the periorbital region, lid retraction, watering, and redness of the eye. So the most common age group to be affected was between 30 to 60 years. The oldest patient was 66 and the youngest was a 22-year patient. So imaging modality, 14 patients used MRI as the imaging modality and 2 CT was done. So MRI is the most common imaging modality preferred. So treatment given, steroids, 7 patients were started on low-dose steroids, 3 patients received rituximab and methotrexate and HCQ were the other treatment modalities used. Orbitotomy and excision biopsy. So out of the 10 patients we have done orbitotomy. And regarding the status of the patients now, 18 patients are under remission and 2 patients have the residual diseases like ptosis, restriction of movements, etc. So case example, this is case 1. He is a 62-year-old male who attended the ophthal OPD with complaints of right eye proptosis, pain and redness. He had comorbidities like diabetes, hypertension and hypothyroidism. MRI orbit shows diffuse infiltrating mass which does not respect the orbital planes. So anterior orbitotomy was made and biopsy was sent. The histopathology report shows lymphoplasmocytic infiltration around the germinal centers and eosinophilic granuloma was observed and fibrosis was seen. So immunohistochemistry came positive for IgG4 disease. He was started on tablet prednisolone and tablet methotrexate. Initially, mycophenolate mofetil was started, and since the patient did not respond to it, injection rituximab 1 gram was used. So he has received 3 doses of injection rituximab so far. And now the patient is in remission. The case 2 is a 44-year-old female with complaints of right upper lid swelling and redness. So MRI orbit shows diffuse infiltration of the right orbit, and the anterior orbitotomy was performed and incision biopsy of the mass showed lymphoplasmocytic proliferation. So she was started on a short-term course of steroid tablet prednisolone for 3 months followed by HCQ. Methotrexate was used and now the patient is in remission. So take-home points. This study shows no merit in advising serial steroid therapy in every acute episode of orbital OID. Serial steroid therapy will lower the diagnostic yield when biopsy is eventually done. From this study, it is evident that early biopsy followed by short-term steroid therapy helps with early induction of immunomodulation helps in long-term remission of the disease. Early biopsy and early immunomodulation is the evidence-based approach for treating OID validated by multiple studies all over the world. So this is the same patient at initial presentation, and after a short course of steroid and immunomodulation, she is in remission now. So this is the pic after the treatment. And these are my references. Thank you.
So only based on MRI findings you decided to do the biopsy, is it?
Clinical features of the
clinical
patient.
and MRI.
And MRI.
No trial was given at all for all of them?
No, ma'am.
Steroid trial?
Initially, a short, in the active state of the disease, a short course of steroid was given for 3 months, slowly tapered down.
No, but early biopsy you are advising, no? So how early you have done the biopsy?
Within 3 months, ma'am. Giving repeated dose of steroid will lead to immunosuppression, so the biopsy yield will be less.
Only you gave 1 course of steroid. Is
Some
it that?
If the patient goes to remission, it is okay, ma'am. If there's flare-up of the disease, repeated courses of steroid
No,
is
no,
used.
no. I am asking when did you do the biopsy for every patient? Like, is there a criteria to?
With 3
See,
months,
a patient
yes, ma'am.
comes with inflammatory disease, acute. You gave 1 course of steroid, or you gave only 1 course was given for everybody, or what? How was it?
It depends upon the clinical condition of the patient, ma'am. Some required multiple doses of steroid. 3-4 times we have repeated the steroid treatment, ma'am. And we have started early immunomodulation, so it leads to the
No,
suppression
no,
of the
I'm
disease.
asking about biopsy. Early biopsy, what stage and what duration you did, and all cases were done at the similar duration?
No,
or
ma'am, out
what?
of the 20 patients, only 10 patients we have done an early biopsy within 3 months of suspecting the disease, ma'am.
Okay, that's what I wanted.
Yes. Thank you, ma'am.
Good morning, everyone. I'm Dr. Neeraja Verma, first year primary DMB resident. I'm here to present my paper. Surprises more often than not. So, a clinical diagnosis of ocular lesion is based on history, appearance, while the final diagnosis is based on the biopsy. Oftentimes, we may find that the biopsy result may surprise us and might be quite different from what we initially suspected. So, this study aims to identify these excision biopsy surprises in the past 5 years at a tertiary eye hospital and to highlight the importance of HPE in every biopsy. So it's a retrospective study, and all excision biopsy cases from January 2019 to May 2024 were taken, and the clinical records of all patients were examined and compared with the HPE findings, and the surprises were identified. So out of a total 172 biopsies, 28, that is 16% were surprises, and out of the 28, 57 were from eyelid, orbit, and then conjunctiva adnexa consists of 29%. So for convenience, we have divided them into 3. So coming on to the biopsy surprises in the eyelid, we found that the hydrocystoma were the most misdiagnosed, while sebaceous gland carcinoma was the most overdiagnosed. So hydrocystoma typically presents as a cystic lesion in the lid margin. Here we have a case with a cystic lesion with the bluish yellowish tinge, so we suspected an inclusion cyst or a cyst of mole, but the biopsy result turned out to be a hydrocystoma. A sebaceous gland carcinoma is one of the most common malignancies of the eyelid in India, and it's a solitary nodule with disruption of the eyelid margin and the eyelashes. So here we have a case with a nodular lesion with the disruption of the eyelid margin and the eyelashes. We are suspecting an SGC, but the biopsy showed to be a mucinous eccrine carcinoma. Another case of the right upper lid medial third lesion with loss of lid architecture and eyelashes. An incision biopsy was done and it was found to be a lymphoma. Another case, we have a young female with a left eye upper lid swelling with SCH. We were suspecting a similar malignancy, but the biopsy turned out to be amyloidosis. Another case, we have a nodular lesion on a 10-year-old boy in the upper lid. We are suspecting a junctional nevus, but on biopsy research, it was found to be a juvenile xanthogranuloma, which is a very rare lesion in the upper eyelid as a mostly presence in the skin. Next, in the orbital lesions, first we have a young 20-year-old male who came with a swelling in the upper supromedial part of the left eye. On CT, we can see a well-defined mass in the anterior part of the orbit, a hypotense lesion, extracorneal. We're suspecting a sebaceous cyst, but in biopsy result was found to be Chimeras disease. We should also, the patient had peripheral eosinophilia, and other systemic association must also be looked into. Next, we have a case with a lesion in the right cheek since past 10 days. I don't have the clinical image, but the CT showed a well-defined lesion. We were suspecting a sebaceous cyst, but the biopsy turned out to be nodular fasciitis. Another 80-year-old male with diffuse swelling in the left eye after cataract surgery since 8 months. We've been suspecting an ocular malignancy as it's covered the whole orbit from the preseptal region to the apex. But on biopsy turned out to be a primary cutaneous mucinous carcinoma, which was found with signet cells and positive for CK7. And another lesion with the supromedial part of the right upper lid, and on CT we can see a nodular lesion, well defined. We were suspecting a sebaceous cyst, but it turned out to be a very cystic soft lesion, and a hydrocystoma of the orbit was made. Conjunctiva adnexa, I'd like to show 2 main cases. So, mass in the lateral wall of the nose, which was soft and non-tender. A well-defined mass in the lateral wall of the nose was seen. And on HP, we found a lobular capillary hemangioma. Lastly, we have a similar case in the lateral wall of the nose. It was a tense lesion. It was, unlike the other one, it was tense.
study period was?
Study 2019 January till 2024 May, so 5 years.
Thank you for the presentations.
Thank you, postgraduates, for your second session and for all the papers. And we'd like to thank our 3 judges as well for taking time out and coming and judging your session.
Thank you for the opportunity. Thanks.
And as a
Nice
small token-
presentations.
Thank you so much. On behalf of the university, thank you so much. On behalf of the university, thank you so much. No, ma'am, we'll total. Thank you. The postgraduates, you all can just inform the rest of your friends as well that the results will be announced by the BOS, and they will get back to you and they will get in touch with you. Okay, it won't be announced in not today and tomorrow. The committee will decide and they will inform you.